The depth of invasion has been found to be an important factor in reshaping the staging system. As we can see, the tumor stage gets upgraded based on a DOI cutoff values of 5 and 10 millimeter. And this particular study was done to identify the pattern of neck node metastasis in oral tongue squamous cell carcinoma and to correlate it with the depth of invasion in our group of population. The objectives, to correlate clinically and histopathologically the incidence of neck node metastasis, as well as to study the pattern of nodal metastasis in squamous cell carcinoma of tongue in relation with the depth of invasion. So coming to metrology methods, this was a retrospective analysis which is done from January 2021 to December 2023. Basically, it was a 3-year study period. It was conducted in a department of head and neck surgery, Dr. B. Bora Cancer Institute, Guwahati, and we included around 110 patients, including males and females. And the patients who attended the head and neck surgery OPD and subsequently got treated for tongue cancer were included in the study period. Under inclusion criteria, we have all the upfront cases of squamous cell carcinoma of tongue who underwent surgery with or without adjuvant therapy, that is radiation or chemotherapy. And we included the adult patients, that is more than 18 years of age. Under exclusion criteria, we have the recurrent or any second primary cases, any patients who had undergone any previous neck surgery or who received radiation or who received neoadjuvant chemotherapy. Coming to results, from this study we can see that the most commonly affected age group was the 51 to 60 years age group with around 38.2%. Among the gender, the most commonly affected gender was the male population with around 55.5%. Coming to T-staging, we can see that the most commonly affected, the patients who presented to our OPD were from the T3 stage, like with around 43.6%, followed by T2 with 30%, followed by T4, and lastly T1. Coming to depth of invasion, the patients who presented to our OPD had the depth of invasion of around 6 to 10 millimeter. It was the most common. The patient presented to us with this depth of invasion most frequently, that is around 37.4%, followed by 0 to 5 mm, that was 31.8%, ultimately followed by 11 to 20 millimeter, which was just around 30%. If you look at the level of nodal metastasis, the most commonly affected level of node was level 2 nodes with a frequency of around 45 number of people with percentage of 40.9%, followed by level 1B node. And if we look at the depth of invasion, if we try to correlate with the nodal metastasis, we can see that as the depth of invasion increases, there's a high prevalence of nodal metastasis. So we can very well see in this chart, like in the less than 5 mm group, we can see that there's around 48.5% node positivity. And as we go higher up, if the depth of invasion keeps on increasing, like from 6 mm to 10 mm, we can see around 70% positive node, and from 11 mm to 20 mm depth of invasion, we can see around 84.8%. Whereas in the last group, where we have more than 20 mm depth of invasion, we can see around almost 100% positivity of neck nodes. So coming to discussion, so I'd like to quote one paper. This is one paper by a landmark paper by Ibrahimi et al., where they looked at the depth of invasion, whether it is an indication of post-operative radiotherapy in oral squamous cell carcinoma. In this study, they have found that with every 5 millimeter increase in depth of invasion, there was a significant increase in disease-specific mortality as well as loco-regional failure. So we've seen that tongue has shown a higher risk of cervical nodal metastasis as compared to other subsites. Probably that is because of abundant lymphatics. And of the different histopathological variables that was related to neck metastasis, the most important one is depth of invasion. And our study shows that in the depth of invasion of more than 20 mm, there is almost 100% positivity of metastatic neck node, followed by 11 to 20 mm, which is 84.8%. So there is increasing pattern of nodal metastasis with increase in depth of invasion, and it shows a clear indication of neck dissection in advanced depth of invasion. Coming to a conclusion, our study has shown the increase in incidence of nodal metastasis with increased depth of invasion, and it is also found that nodal metastasis has been shown to be increased in depth of invasion even in less than 5 mm with 48.5%, and in 6 to 10 mm with 70% as these groups come on T1 and T2 stage of 8 edition of TNM classification, which mandates elective neck dissection even in early cases of carcinoma of tongue. So our study has validated the AGCC 8 staging in the Northeast population, because most of the patients coming to our OPD are from the Northeast belt. So we have validated the AGCC 8 staging from this study. These are my references. Thank you.
Okay, Dr. Rupjyoti, nice presentation. Thank you. May we have the next speaker? Dr. Bijit Saikia. Your topic is use of posterior belly digastric branch of the facial nerve to identify facial nerve trunk in doing periodictomy.
Hello.
Dr. Bijit, kindly introduce yourself, because
Good morning, all the members present here. My name is Dr. Bijit Kumar Saikia. I'm currently practicing as a registrar in Borpeta Medical College. Thank you. Okay, so we'll start with the presentation. My topic is use of posterior belly digastric branch of the facial nerve to identify the facial nerve trunk in doing periodictomy. So surgeries on the periodic gland, it has undergone a long history of evolution till the present status today. So detailed accounts of early periodictomy were published by Carmichael of Dublin in 1818. In 1835, Balpao described this procedure of finding the facial nerve using superficial temporal artery and vein. 1921, Seastrunk, Edson, and Ott proposed finding the facial nerve by tracing the marginal mandibular nerve, and Hamilton Bailey in 1941, Shuck-Smith in 1953, and Hayes-Martin in 1952 commented that finding the facial nerve at its emergence, at its stylomastoid foramen, is the best way to find it. So still, the proper identification of the facial nerve and doing surgery over it and preserve the functions is still a stiff challenge, and so various pointers have been identified which helps in finding out the facial nerve. Some of these most commonly used are the tympanomastoid sutures along with these numerical measurements, the tragal pointer, the posterior belly of digastric muscle, the mastoid process, the stylomastoid artery, the marginal mandibular and buccal, which are the retrograde branches, and then we have presented a sixth, that is the nerve to the posterior belly of digastric. These numerical measurements, they differ by race, age, presence of tumor and sex, and except for a branch to the posterior belly of digastric muscle, all the other indicators, they require an extra surgical step to get the facial nerve. Tracking this branch is the only surgical step where a surgeon can reach the facial nerve without doing any surgical maneuver on top of the facial nerve trunk. So 15 patients were operated using this pointer, and it was operated by a single surgeon, JP. Then all the periodic tumors, irrespective of age and sex, were without facial nerve paralysis were included in the study, and lesions involving the skin, the preoperative facial nerve palsy, and irradiated patients to the head and neck were excluded from this study. So we'll just give a series of videos demonstrating the procedure. So first we'll start with the cervical incision, which is given from the lobule to the upper cervical crease with a distance of about 5 centimeters. So after the incision, we delineate the sternocleidomastoid and the anterior border, and then we identify the greater auricular nerve and try to preserve the posterior branch. So you can see the nerve being preserved. Then the posterior projection of the parotid gland over the sternocleidomastoid is dissected out, as you can see here. We use the blade, surgical size 10 blade. Okay, so next we now get access to the posterior belly digastric by going below the sternocleidomastoid. So we can see we're working above the posterior belly digastric branch, and we are trying to remove the tissue from its attachments to the muscle. Okay, so you can see the digastric muscle coming into view. Okay, so next, the digastric muscle is now traced up to its insertion point, and that is near the mastoid tip. Not, sorry. We have to focus on the depth of the muscle, because this point, that is the depth, is important while dissecting. Next. So we can see the nerve now that is entering the muscle, that is at an acute angle in its superior and medial border. We can very clearly see. I think the screen is not doing justice. But we can see the nerve. So very lot of times it's seen at an acute angle in its superior and medial border. So after tracing this nerve, we further undergo dissection, and then about 2 to 2.5 centimeters we will see the facial nerve trunk. That is, after tracing the posterior digastric branch, we railroad it, and after 2.5 to 2 centimeters to 2.5 centimeters we will see the nerve. And then we can see the facial nerve trunk. You can see the facial nerve trunk here very nicely. Okay. So after identifying the nerve, it is found to be associated with the stylomastoid artery. And then keeping the surgical field vertical to the muscle, we trace the facial branch, and we could find it a distance of 1.5 to 2 centimeter. The facial nerve could be reached without any maneuver on top of it, unlike other landmarks where the surgical field needs to be exposed further to get the facial nerve trunk. So these are a few pictures showing the branch to the posterior digastric, the facial nerve trunk, and the branch to posterior digastric, and the facial nerve exposed completely. So these are post-operative pictures of patients. We can see the incision, and the results. So it can be found in all the cases. It was a consistent and reliable network, reliable nerve. The thicker nerve than maxillomandibular and easier to be identified. Entry of nerve to muscle is around 1.5 centimeter. We discussed. It gives better control of stylomastoid artery. And in tumors involving parotid tail, the muscle is taken up by tumor. Hence, we had to take the surgical field down to the tendinous point of the muscle. And so these are my references. Thank you.
So thank you, Dr. Soiga. Very nice presentation. So it is always a challenge identifying and preserving the facial nerve in parotidectomy, especially for the beginners. So, thank you very much once again.
Thank you, sir.
So now, Dr. Taba Nitin. So she will present. Acha. Okay, so he will present a rare case report, rares of the rare, a case report on hypopharyngeal primary neuroendocrine carcinoma. So I am requesting Dr. Taba to kindly give a short introduction.
Dr. Umaro, you are around?
Hello. Good morning to everyone present here today. Myself, Dr. Taba Nitin. I am currently pursuing fellowship in head and neck oncology at SCI Guwahati. So today I am presenting a very interesting case of the rarest of the rare, a case report on hypopharyngeal primary neuroendocrine carcinoma. Primary neuroendocrine carcinoma are very rare entities accounting for 0.49% of all malignancies. They most commonly occur in the intestine, where they are often called carcinoid tumors, but they are also found in pancreas, lung, and the rest of the body, including head and neck. So neuro refers to the dense core granules similar to DCGs in the serotonin neurons storing monoamines, whereas endocrine, the name refers to synthesis and secretion of these monoamines. Neuroendocrine carcinoma of head and neck is very uncommon. Approximately 35% are found in the larynx, 30% in the nasal cavity and paranasal sinuses, 12% in the oropharynx, 10% in nasopharynx, 9% in oral cavity, and 4% in hypopharynx. To date, only few cases of primary neuroendocrine carcinoma of the hypopharynx have been documented. With no established treatment guidelines for this rare tumor, various treatment approaches have been employed, including surgery, radiotherapy, and chemotherapy. In this report, we detail a rare case of mixed small cell neuroendocrine carcinoma and squamous cell carcinoma of the hypopharynx. A 68-year-old male presented with swallowing difficulty and sticky sensation in throat for the last 2 months and hoarseness of voice for 1 month. He is known case of squamous cell carcinoma of the right piriform sinus, for which he received radiation therapy from 18/9/2018 to 12/11/2018 and was on regular follow-up. He does not give history of any comorbidities. He gives history of more than 40 years of cigarette smoking, but stopped since 2018 after being diagnosed with CA right PFS. On examination, GC failed PS ECOG1, examination of the oral cavity and oropharynx, no growth seen or palpated. Neck, no palpable lip adenopathy, and laryngeal crepitus was present. Investigations, we did pan endoscopy. In the fiber optic laryngoscopy revealed ulcero-proliferative growth in the left PFS. The apex post-cricoid region was free of tumor. However, there was restricted mobility of left vocal cord movement was noted, and right vocal cord was normal. Whole body PET-CT was done, which revealed increased FDG uptake seen in heterogeneously enhancing mass in left PFS, measuring 2.3 into 1.7 into 3.8 millimeter, and SUV max of 6.8 with thyroid cartilage erosion. No other significant metabolically active disease elsewhere were found. So punch biopsy was taken, which shows small cell variant of neuroendocrine tumor of the left PFS. It was chromatin A positive, synoptopysin positive, PanCK, INSMI, and Ki67 positive. So after complete workup and diagnosis of a small cell neuroendocrine carcinoma of the left PFS was considered CT4A and 0M0. In the multidisciplinary tumor board, the patient was presented in and planned for salvage total laryngectomy for plus bilateral LND plus left hemithyroidectomy and PMMF repair was planned. Patient developed stridor and breathing with difficulty during the workup period. After thorough discussion and written and informed consent, patient was prepared for surgery. So these are some of the beautiful pictures of intraoperative pictures. You can see in this picture, this is the epiglottis. Total laryngectomy and partial pharyngectomy was done. This is the posterior pharyngeal wall that was left behind after laryngopharyngectomy. This is the post-op specimen. You can see the epiglottis, the tumor itself in the left PFS. So then we harvested the left PMMC flap, and since it was less than 3 centimeter, so defect was repaired using the PMMC. Immediate post-op period, patient was shifted to ICU and kept under observation for 24 hours. Vitals were monitored, shifted toward the next day, and RALS to feeding was started. Post-op stay in hospital was uneventful and was discharged on POD4. So patient was on regular follow-up. On the first, this is the picture of POD21, the patient himself. You can see the stoma. This is the scar of the PMMC. The patient was followed after 10 days. Wound was healthy. All the sutures were removed. So post-op HPE came out to be combined small cell neuroendocrine carcinoma and squamous cell carcinoma positive for IHC markers previously described, like synoptopysin and chromogranin. You can see both the components are present here, and all the margins were free of tumor, absent lymphovascular and perineural invasion, PT4A and 0, and patient was being planned for adjuvant RT plus CT. This, in 1972, Olofsson and Van Nostrand documented the first case of primary extrapulmonary neuroendocrine carcinoma originating in the head and neck. Since then, occurrence of this tumor have been noted at various locations within the upper aerodigestive tract, including the larynx, paranasal sinus, and salivary glands. However, hypopharynx remains a rare site of NEC. For a small number of patients with NEC of the hypopharynx, multimodal therapy including surgery, radiotherapy, platinum-based chemotherapy has been commonly employed, yielding various outcomes. At last, I would like to conclude with combined SCC with NEC of hypopharynx is very rare. This is the second documented case till now. The first documented case was in 2010 by Alfio Fertillo et al. Since it is a very rare tumor, no established treatment guidelines are there. Our patient is under regular follow-up and doing well at present. And there is importance of individualized treatment approaches and vigilant monitoring is required. These are some of my references. Thank you.
Thank you, Dr. Taba, for this, presenting this rare case. Just one question. It was, yes, he has history of previous, some years back, na?
Yes, yes, sir.
Squamous cell carcinoma.
Squamous cell carcinoma, right PFS.
So the next second time disease was in the same.
No, sir. It was in the different location. In the left PFS, it happened.
Opposite side.
Opposite side. Yes.
That's what I meant. Okay. So it was not related to.
Not related to previous tumor. Yeah.
We have another presentation, Dr. Uma Roy. Dr. Uma Roy.
Okay, thank you, Dr. Taba.
Thank you, sir.
Thank you, sir.
Dr. Uma, can you introduce yourself?
Good morning to one and all present here. I am Dr. Uma Roy. Currently, I am pursuing fellowship in head and neck oncology in State Cancer Institute, Guwahati.
Yeah, as the paper was in the Swami Vivekananda category, so we could not include here in the agenda, but she'll be talking on assessment of speech and swallowing after laryngectomy in laryngeal and hypopharyngeal malignancies. I request all the previous speakers to be in the hall for question answer session and also felicitation program.
Today I will be presenting a paper on assessment of speech and swallowing after laryngectomy in laryngeal and hypopharyngeal malignancies. Introduction. Total laryngectomy, a surgical treatment for laryngeal and hypopharyngeal malignancies, profoundly affects patients' swallowing and speech abilities. This procedure significantly impacts patients' quality of life, often leading to physical, psychological, and social challenges. Comprehensive assessment of functional outcomes following this procedure is essential for developing effective rehabilitation plans. Patients' functional status after treatment for head and neck cancer is not well reflected in health-related quality of life studies, especially for laryngectomies. Among the affected functions, swallowing presents as a significant challenge for patients post-laryngectomy, impacting nutrition and quality of life. Identifying factors that influence postoperative swallowing function and speech is crucial for improving outcomes and developing rehabilitation strategies for laryngectomy patients. Aims and objective. Aim to assess speech and swallowing outcomes after laryngectomy for laryngeal and hypopharyngeal malignancies. Objectives: evaluate normalcy of diet, public eating ability, and speech comprehensibility using the performance status scale. Compare outcomes between patients less than and more than 6 months post-laryngectomy. Materials and method. It is a hospital-based prospective study undertaken in Department of Head and Neck Oncology, State Cancer Institute, Guwahati. Sample size is 42 patients and study duration is January 2023 to July 2024. An assessment was, statistical analysis was done with students' t-test. Methodology. After obtaining institution's ethics committee approval, performance status scale for head and neck cancer was evaluated. Normalcy of diet scored from 0 to 100, assesses ability to eat various food consistencies. Eating in public scored from 0 to 100, measures comfort and ability to eat in social settings. Speech comprehensibility scored from 0 to 100, evaluates clarity and understandability of speech. This is the performance status scale for head and neck cancer. Eating in public, 100 score is given when there is no restriction of place, food, and companion. 75, no restriction of place but restricts diet when in public. 50, eats only in presence of selected persons in selected places. 25, eats only at home in presence of selected person. 0, eats always eats alone. Understandability of speech, 100, always understandable. 75, understandable most of the time, occasional repetition is necessary. 50, usually understandable, but face-to-face contact is necessary. 25, it is difficult to understand. And 0, never understandable, may use written communication. Normalcy of diet, 100 is given for full diet with no restrictions, 90 for peanuts, 80 for all meat, 70 carrots and celery, 60 dry bread and crackers, 50 for soft and chewable food, 40 for soft food requiring no chewing, 30 pureed food, and 20 warm liquid, 10 cold liquid, and 0 no oral feeding and tube feeding. Results and discussion. Based on the observation, 42 patients who underwent laryngectomy for laryngeal and hypopharyngeal malignancies, 33 were male and only 9 were women, and 78.6% versus 21.4%, with mean age of 64 plus minus 10.7 years. Performance status scale for head and neck cancer yielded mean scores of 83.5 plus minus 17.7. For normalcy of diet, 76.4 plus minus 21.3 for eating in public, 61.4 plus minus 16.7 for speech comprehensibility. Regarding diet and eating capabilities, more than half of the patients, 53.2%, were able to maintain a full diet without any restrictions. Even more promising was the finding that approximately 90% of the patients could manage to swallow at least soft and chewable food. Only a small proportion, 5.1%, required tube feeding for nutrition. For normalcy of diet scores, at least less than 6 months post-laryngectomy, 81.2% plus minus 18.3% did not significantly differ from the scores more than 6 months post-laryngectomy, 85.7 plus minus 16.9. In contrast, eating in public scores showed statistically significant improvement from a mean of 68.9 plus minus 23.1 at less than 6 months to 83.8 plus minus 17.2 at more than 6 months post-laryngectomy. Speech outcomes also showed positive results, though with more variation. While 13.9% of patients achieved complete speech understandability, nearly half, 48.1%, were understandable, most of the times requiring only occasional repetition. Very few patients, 2.5%, experienced complete speech incomprehensibility, requiring written communication. Similarly, speech comprehensibility scores improved significantly from 54.6 plus minus 17.8 at less than 6 months to 68.2 plus minus 12.4 at more than 6 months post-laryngectomy. This is a result showing treatment-based performance status scale. For salvage TL, total laryngectomy, normalcy of diet was 79.8, eating in public was 81.1 plus minus 24.2, and speech comprehensibility 65.2 plus minus 22.5. And total laryngectomy plus radiation therapy, there was normalcy of diet was 79.4 plus minus 28.8, and eating in public 71.1 plus minus 32.4, and speech comprehensibility 63.3 plus minus 24.7, and near total laryngectomy plus radiation therapy, normalcy of diet was 90.7 plus minus 26.4, eating in public 85.7 plus minus 36.3, and speech comprehensibility 69.6 plus minus 14.5. The treatment, the type of treatment did not significantly affect patients' functional outcomes in terms of eating, speech, and public dining abilities. This suggests choice of treatment approach does not substantially impact post-operative quality of life. Conclusion, post-laryngectomy functional outcomes improved over time. Normalcy of diet scores stabilized quickly post-surgery. Eating in public and speech comprehensibility showed ongoing improvement beyond 6 months. Long-term rehabilitation should focus on social eating and speech function. These are my references. Thank you.
Thank you.
I request all the speakers to come in front for question answer session.
Ma'am.
So only 2 questions are allowed per speaker. Maximum 2 questions.
Did all your patients in your series undergo a rigorous speech and swallowing rehabilitation post-laryngectomy? Did all your patients undergo do all your patients after laryngectomy undergo rigorous speech and swallowing rehabilitation always?
We have included here the patients without complications like PCF. We have excluded those patients. Only the normal patients we have included.
Okay. The patients were rehabilitated. What were the methods of rehabilitation or speech restoration that you utilized?
Surgical restoration of voice was usually preferred in our institute. That is primary TEP. Then we ask the patient to follow up, and the follow-up period we insert voice prosthesis.
Not at the time of TEP, or you do it later on?
Sir, we do primary TEP, then we ask the patient to follow up. After 2 weeks, we insert the voice prosthesis.
And during that period?
And we also ask the patient to go for speech and swallowing therapies.
And what do you do with the puncture site for these 2 weeks?
We insert 14 gauge Ryle's tube.
Okay, right. Did you have any of the patients with electronic voice?
Sir, I found one patient who came for follow-up and was operated previously 3-4 years back.
Okay, and esophageal speech?
Esophageal, yes, sir.
You had patients?
We get patients.
No. Esophageal speech post laryngectomy, post total laryngectomy.
Yes, sir.
Not the TEP voice, not the electrolarynx, but the esophageal speech.
Yeah, in near total laryngectomy patient.
No. It's not near total. That is total laryngectomy. Patients developing speech by using the esophageal air as bellows for producing the speech voice. You didn't have, okay. So nowadays it's quite rare actually, because even speech therapists probably many of them are not very used to giving esophageal speech with the development of the tracheoesophageal voice prosthesis. Thank you so much.
Thank you, sir.
Good study.
Thank you. Next, Dr. Rupjyoti. Any question for Dr. Rupjyoti? He presented on a paper on tongue malignancy.
So Rupjyoti, let me ask you.
Dr. Das.
Do you have any patient with contralateral node involvement in a disease where the disease has not reached the midline?
So sometimes we do get cases like Sir, basically based on a post-op biopsy report, and whenever in tongue malignancy cases, whichever malignancy, if it doesn't cross the midline or it doesn't tip, we generally don't address the contralateral lymph node. So we are since we don't address the contralateral lymph node, it is difficult to say based on post-op biopsy whether the contralateral lymph node is involved or not. So but yeah, sometimes if we find cases where it has crossed the midline, it has crossed the midline to the opposite side, then we do address the contralateral lymph node, and we have found positivity in.
No, I'm talking about unilateral disease. You don't try any sentinel node biopsy or say frozen of the L1A.
Yeah, sometimes we send.
When you have a significant node in 1A.
Yeah, so we do send it for frozen.
You better go for a frozen, and in that case, if it comes positive, you better go for contralateral, at least 1A, 1B.
Yeah. So when we find any suspicious node in level 1A, basically, we send it for frozen, and if it comes out to be positive, then we do get go over to the contralateral lymph node dissection. Sir.
Okay, next. नाम का
tongue malignancy. Basically, ma'am, depth of invasion is a histopathological parameter. So it's all about, sir, ma'am, we have to rely on the post-operative histopathological report. MRI, MRI pre-operatively we can look for development by doing an MRI scan. Basically, in case of tongue malignancy. So basically, we in tongue malignancies we prefer to go one step ahead. Like we prefer to clear level 4 also, because there's a landmark paper by Dr. Byers. So where it has shown around 15 to 16%. So Dr. Byers. So there is around 15 to 16% rate of metastasis in level skip metastasis to level 4. That paper has shown that result. So we go ahead and we clear out the level 4 itself. But sir, in our institute, we make it a point to do the extended supra neck decision as well. So extended.
Okay, any question for Dr. Soumya?
Soumya, I have a question for you. Sorry, I am asking so many questions. Soumya, thing is that how do you differentiate between a spasm and a stricture?
Yes, sir. This is a very nice question. Basically, stricture we go endoscopically to see the neopharynx, sir. And spasm is a clinical term. Patient will have very strenuous speech. Despite of that, patient won't be able to produce the voice. But while passing the endoscope, while doing an endoscopy, if a stricture is there, we will not be able to negotiate the scope beyond the stricture side. So it has to be dilated properly, then and stricture and spasm.
And again, when it comes to spasm,
Yes, sir.
don't you think that you missed something during the surgery that is causing the spasm?
Yes, sir. Every case we do cricopharyngeal myotomy,
Then
but yes, sir, myotomy is performed in every cases, but healing
May-
differ in patient to patient. Sir.
maybe the myotomy is inadequate, leading to a spasm, because if you do a proper myotomy, you
Yes,
should
sir.
see your finger inside the
Yes, sir.
esophagus. Then only you can be sure that there will be no stricture,
Yes, sir.
spasm. Sorry.
Thank you, sir.
Okay, any other question?
The paper by Dr. Bijit Soikia, use of the posterior belly digastric branch of the facial nerve. Now, this is a very tricky thing to do. We have never tried it. So, and the pictures you showed, the picture was not zoomed in properly, so we couldn't really appreciate where you found that branch. Can you?
So that we found the branch, we traced the posterior belly digastric muscle to the insertion point. Then 1.5 centimeter, just before its insertion, we will find a nerve entering it at near the superior and medial border at an acute angle.
Yeah, we also trace it, but probably we never looked for that branch. We did go and look for the main trunk itself.
Yes, sir.
So that may be a pointer for careful searching for that branch, I suppose, in the future.
But to explore the surgical field, sir, because we use triangulations to search the gland. So in that time, we have to work above the gland, but about 1.5 centimeter distal to the insertion with the largest. Yes. No, not from the main trunk, from the insertion point of the digastric muscle.
How many cases have you done here?
So till the study was conducted, we have done 15 cases, 15, sir.
Oh, that's quite a number. I think once you get 15 cases, you should report this.
Yes, sir.
Okay, thank you so much.
Thank you, sir.
Vijit, I really appreciate you. You showed us a new thing. I must congratulate you and Jyoti Mehta. Actually, it's a fantastic thing. We have very often, now retrospectively, I remember I have seen that nerve many a times and I have simply cut it and thrown it away. Never utilized it. Next time I'll utilize it.
Thank you, sir.
Thank you.
Taban, any questions for Tabanitin?
Any question?
If no questions, then we can wind up the
end
session.
Okay.
Dr. Kunesapi.
Anatomical location wise, it is in the larynx as a whole, in the head and neck. It's benign. Yes.
So, are we?
One speaker, Kunesapi, private, left. Any question?
Kunesafi, can you come forward? Okay. Any questions for Kunesafi?
Where was this You're from which? Guwahati Medical College. Okay. So this was done over a period of 10 years.
10 years, sir.
And you found about 40, 60 odd cases.
Around 64 cases, sir.
Okay. Right. Thank you so much. Thanks.
Thank you, everyone. Thank you, Chairperson. Now we are going for felicitation program. I request all the speakers to come to the felicitation platform. Please go forward. I request all the speakers. I request Ms. Gayatri and Anushka to help us in felicitation program. I request Chairperson to felicitate the speakers. And I request the photographer to take a photograph. Yeah. Dr. Tabanitin. Dr. Umar Roy. Dr. Rupjyoti Das. Dr. Bijit Sarkia. Dr. Soimyaji. And Dr. Kone Safi Pirabat. Now I request SB Fukan sir and to felicitate our chairperson. Please come forward. You can take a photograph together. Yeah. Thank you, everyone, and you can take the platform for to have a photograph together. Now we are going to start our next session, award session. We have 3 awards. First is the S.N. Sharma Award. The speaker is LH Hiranandani LH1 Award. Can I call upon Dr. Imli Wabang to chair the session, and also Dr. Bipul Barua. And speaker is Dr. Rohan Nanda Barua. He is the winner of LH1 Award. You have 15 minutes for your presentation.
I think we should not say that. Huh? We should not say. On his own, he is there. Okay, go ahead and have introduction. No, he will introduce himself.
Good morning, delegates and faculty and organizing members. I am very grateful to Academy of Shivsagar and Nebai for giving me the opportunity to share this session. Dr. L.S. Hiranandani was a Mumbai-based otolaryngologist, social activist and philanthropist. He developed many ENT procedures and it is known as Hiranandani operations. And he received many prestigious awards including Padma Bhushan in 1972, and he also contributed many things to the ENT fields. And he died in 2013 at the age of 96 years. So without delaying, I request Dr. Ruhan Malla Barua to present his award paper, which hello?
Good morning to all present here. At the very outset, I sincerely thank the judges and the organizer for selecting my paper worthy of this prestigious L.S. Hiranandani Award. My paper is Effect of Adenotectomy in Reducing the Incidence of Recurrent or Chronic Nasal Obstruction and Upper Respiratory Tract Infection in Children. The adenoid is a part of Welder's ring of lymphoid tissue in the nasopharynx. The adenoid has a protective function against the organism entering the upper respiratory tract via the nasal cavity. The lymphoid tissue in the adenoid is stimulated by the exposure to antigen or bacteria, leading to lymphoid proliferation, inflammatory reaction, and bacterial infection of the adenoid, which are the causes of adenoidal hypertrophy, and the adenoid becomes the reservoir of bacteria in the upper respiratory tract. Chronic nasal obstruction, rhinorrhea, mouth breathing, snoring, and ear-related symptoms such as muffled hearing, otalgia, crackling or popping sounds in the ear, recurrent middle ear infections are some common symptoms of adenoid hypertrophy. This combination of symptoms has been shown to significantly affect the quality of life, often resulting in behavioral changes or emotional distress. Current management of chronic nasal obstruction includes allergy treatments, the use of nasal steroid sprays, and surgical intervention when the medical management fails. An acute upper respiratory tract infection is the most common diagnosis in children in primary care. Every year, the diagnosis is made in 1 in every 2 children aged 0 to 4 and 1 in 10 of those aged 5 to 9. Nasopharyngeal colonization by bacterial pathogens is a primary stage for the development of upper respiratory tract infection in young children due to Streptococcus pneumoniae, Haemophilus influenza, Morixella catarrhalis, and Staph aureus. This study aims to evaluate the effectiveness of adenotectomy in reducing recurrent or chronic nasal obstruction and upper respiratory tract infection in children. Additionally, it seeks to review the bacteriology of the adenoid. This prospective study examined 60 children admitted for adenotectomy. It was conducted at NMB Borua Nursing Home in Nalbari from January 2020 to January 2022. Children aged 4 to 13 years with adenoid hypertrophy and nasal obstruction were included in the study. Cystic fibrosis, immunodeficiencies, previous sinus surgery, craniofacial abnormalities, and chronic tonsillitis were excluded from the study. All the major symptoms were evaluated and documented. All the children underwent nasal endoscopy following the application of topical anesthesia. In cases where children were unwilling to undergo endoscopy under topical anesthesia, the procedure was performed under general anesthesia just before the surgery. Clements and McMurray classification was used for grading the adenoids. The grade 1 is the adenoid tissue filling 1/3 of the vertical height of the choana. Grade 2 is adenoid tissue filling the 2/3 of the vertical height of the choana. Grade 3, adenoid tissue filling between 2/3 to nearly the entire choana but not completely. And grade 4 is the complete choanal obstruction. Routine autoendoscopy and tympanometry were performed for all the cases and values are documented. X-ray soft tissue neck lateral view performed on all the children. The adenoid size and the nasopharyngeal size were measured. The adenoid nasopharyngeal ratio was calculated and scores were graded into mild, moderate and severe. All the patients received medical management for a minimum of 6 months. Following thorough evaluation with nasal endoscopy, the parents were informed about the need for surgery and the study protocols. After obtaining informed written consent, the child was scheduled for an adenoidectomy. There are many techniques for adenoid surgeries. Our approach to adenoid, which I am going to show in the next slide, is using microdebrider. Our surgery will be accomplished in 3 phases. The patient is taken up for surgery under general anesthesia in a supine position. A boiled Javis mouth gag is used to open up the mouth. The nose is decongested with nasal pack soaked in xylocaine and adrenaline solution. A 0° 4 mm endoscope is introduced to visualize the nasopharynx. This is the picture what we get after a proper decongestion. A 60-rad microdebrider is introduced into the nasopharynx through the mouth. The first part is the major developing of the adenoid tissue as seen here. The second part is the complete removal of the adenoid tissue in the perimysial plane. Here we are introducing the blade into the junction of nasopharynx and the oropharyngeal mucosa. Third step is removal of the adenoid tissue from the fossa of Rosenmuller. During the surgery, continuous saline irrigation and adrenaline soaked pack of the nasopharynx is done to keep the field clean and bloodless. Cobbleton is used prophylactically to coblate a few areas where there are few oozes of blood. This is the final picture after adenoidectomy. The post-surgery, we monitor the child for 6 hours and discharge on the same day. Adenoidectomy is generally considered as a safe procedure. However, it can occasionally lead to complications. These are some of the common complications of adenoidectomy: bleeding, dental trauma, phalangeal incontinence, infection, non-traumatic atlantoaxial subluxation, regrowth of the adenoid. Nasal swabs were collected both pre-operatively and post-operatively to assess the microbial colonization. The children were followed up after surgery at 3 months intervals for 1 year to assess the status of their major symptoms and the extent to which these symptoms had changed since the procedure. This study examined the outcomes of adenoidectomy surgery in pediatric patients with nasal obstruction. The research evaluated pre-operative and post-operative symptoms, tympanometry results, medication use, and bacterial cultures to assess the procedure effectiveness in improving the bleeding and reducing the complications. The study included 60 patients, 34 boys and 26 girls. The mean age was 6 years with a standard deviation of plus minus 2.8 years. The peak age group was 4 to 6 years. Among 60 cases, 19 presented with adenoid facies, 28 had hyponasal voice and snoring, and 28 patients had abnormal upper dentition. Preoperatively, the nasal congestion was reported in 82.8% of the patient, rhinorrhea in 43.8%, mouth breathing in 100%, and snoring in 71.6% of the patient. After surgery, the nasal congestion decreased to 9.8%, rhinorrhea to 12.9%, mouth breathing to 3.7%, and snoring to 6.8% of the patients. Overall, 52 patients experienced complete symptoms resolution, 7 had some improvement, and 1 showed no improvement in their symptoms following the procedure. Tympanometry also showed significant improvement 3 months after surgery. The percentage of patients with B-type curve decreased from 61.7% to 11.6%. Our results showed a significant reduction in the use of nasal steroid, antihistaminics, and antibiotics. Preoperative culture was positive in 42 cases. A total of 193 bacterial isolates were identified. Haemophilus influenza was the most common organism, followed by Staph aureus and Streptococcus pneumonia. Moraxella catarrhalis was found in the nasal colonization. Postoperative culture from the nasal cavity and the nasopharynx showed a growth of Staph aureus, Streptococcus pneumonia, and Moraxella catarrhalis. This study demonstrated the effectiveness of adenotectomy in managing chronic nasal obstruction. The procedure showed promising results with many patients experiencing complete or partial symptom resolution. Additionally, the research explored the impact of adenotectomy on upper respiratory tract infection, particularly otitis media with effusion. Our study demonstrated the remarkable efficacy of adenotectomy in managing chronic nasal obstruction. Our results showed 87% experienced complete resolution of their symptoms and 13% reported partial improvement. These findings are corroborated by the study conducted by Peter J. Siolek and colleague. The consistency between these studies underscores the reliability of adenotectomy as a treatment option for chronic nasal obstruction. The high rates of symptom resolution suggest that this procedure can significantly enhance quality of life for patients suffering from this condition. A secondary objective of our study was to evaluate the impact of adenotectomy on frequency of upper respiratory tract infection. These results were promising, showing a significant reduction of incidence of otitis media with effusion post-surgery. These findings align with the study conducted by Burstein et al., which demonstrate the beneficial effect of adenotectomy in decreasing the number and duration of episodes of various upper respiratory tract infection. Our study findings on bacterial colonization in pre- and post-operative cases align with the previous research, particularly that of Brodowski and Koch. Haemophilus influenza was identified as the most prevalent pathogens in the disease adenoid tissue. Interestingly, the difference in pre- and post-operative cases of Staph aureus was found to be significantly insignificant. This corroborates with the findings of Darian et al., who noted that Staph aureus is often present as a commensal organism in the nasal vestibule and the cavity. To conclude, this study confirms the effectiveness of adenotectomy in managing chronic nasal obstruction and reducing the incidence of otitis media with effusion in children. It also highlights the potential benefit of adenotectomy in reducing the frequency of physician visits for upper respiratory tract infection, suggesting positive behavioral changes following the procedure. The present study confirms the observation that almost 50% of the children possesses potential pathogens in the nasal cavity. The role of adenotectomy in the treatment algorithm for chronic nasal obstruction in children now becomes a more logical procedure based on the microbiology of the adenoid and the nasal cavity. The findings from our study and the corroborating research have significant implications for clinical practice in otolaryngology. When evaluation patients with chronic nasal obstruction, recurrent upper respiratory tract infection, clinicians should consider adenotectomy as a viable treatment option. Post-operatively, it is crucial to monitor patients for symptoms improvement and reduction in frequency of upper respiratory tract infection. Long-term follow-up is essential to assess the procedure's long-lasting effects and determine if additional intervention are necessary. The study aims to provide a valuable insight into the effectiveness of adenotectomy in reducing the nasal obstruction and upper respiratory tract infection in children. Further research may be needed to assess the long-term effects of adenotectomy of children's respiratory health. Understanding the bacteriology of adenoid may lead to improved treatment strategies and antibiotic use. Findings may help develop more personalized approach to treating adenoid-related issues in children. Thank you.
Actually, Dr. Rohan Mallab has not been introduced. Actually, he should be introduced because he is the winner of Balichu and Hiranandini. Actually, he is a like father, like son. His father is sitting here, and only second characteristic is that he has trained with Dr. Satish Jain, all the art and everything. Very nice paper. Thank you. And next to chairperson.
Thank you so much, Dr. Rohan Malaparwa, for your wonderful, precise, and elaborate presentation on the LH1 award. Hiranandini would have been proud with your performance because adenocectomy is our bread and butter, for which we all get our roti, kabra, or makhan. So thank you so much. So let's make some noise for Rohan.
Thank you, sir.
Now, I request Dr. Rohan to come to the felicitation dais. May I request Dr. Nicola to do the ceremony? Dr. Ijuana, you can fix your PPT there. Dr. Ijuana? Yeah. No, it's for him only from our organization, from our Nebaoicon organizing committee. Thank you. Nicola, can you felicitate our chairperson? Dr. Emily Among and Dr. Vipul Barua, please come forward. We have amongst us two young ladies from Assam Medical College. They are doing postgraduate, Dr. Gayatri Goswami and Dr. Matri Dev. They will take care of the scientific session from now onwards. Thank you everyone.
Good morning everyone present here. Now we have the L. Hiranandini 2 award, and the chairpersons are Dr. Pranam Malla Borwa, Dr. Hiranya Bora and Dr. Shamim Ahmed. The speaker is Dr. Rizwana Begum on the topic assessment of hypocalcemia after thyroid surgery.
Dr. Ijuana
Yes, ma'am.
She is presently working as registrar in Guwahati Medical College for last more than 2 years. And Dr. Hiranandini LH2 award is awarded to her. And her subject of presentation is the assessment of hypocalcemia after thyroid surgery. I welcome you and congratulate you for this award session, and you can continue your session.
Thank you, ma'am. Good morning, respected chairpersons, faculties and delegates. I am humbled and grateful to the organizing committee for selecting my paper and for giving me this opportunity to present it in this platform. I'd also like to thank my teachers, without whose guidance and blessings I would not be standing here today. So my paper is Assessment of Hypocalcemia After Thyroid Surgery. Diseases of the thyroid gland are quite common. In fact, India has the world's largest goiter belt, which spans from Kashmir in the west to Nagaland in the east, where the level of iodine in the drinking water is extremely low. Management of diseases of thyroid gland forms a major chunk of workload in head and neck surgery departments. Two notable thyroid surgeons were Billroth and Coker. Emil Theodore Coker was in fact Billroth's student, and he can be truly considered as the father of thyroid surgery. He collected data on 268 thyroid operations and identified recurrent laryngeal nerve injury, myxedema, and tetany as serious post-operative complications. Today, the incision is used for thyroidectomy is named after him. These were the two notable thyroid surgeons. Few lines on the pyramidal lobe. It is a conical protrusion present in 12 to 81% of the cases. The prevalence is high enough to warrant exploration in every case of thyroid surgery, and if it is present, it should be removed to the main lobe to avoid leaving behind functioning thyroid tissue. Tubercle of Zuckerkandl, it is lateral or posterior projection identified in up to 60% of cases. Its surgical importance is that RLN most often runs medial to it. Superior parathyroid gland is usually attached to its cranial aspect, and when enlarged as a part of goiter, a significant portion of thyroid tissue may be inadvertently left behind during surgery. For all the cases in this study, we did FNAC, where we used Bethesda system, where we have non-diagnostic benign ATP of undetermined significance, follicular neoplasm, suspicious for malignancy, and malignant as Bethesda 1, 2, 3, 4, 5, and 6. For all cases, we also did ultrasonography of the neck, where we used the TIRAGE system of data system, which is divided into TR1, 2, 3, 4, 5. TR1 is benign, 2 is not suspicious, 3 is mildly suspicious, 4 is moderate, and 5 is highly suspicious. Few lines on the parathyroid glands. There are 4 glands, but the number can vary. 85% of the superior parathyroid glands are within a 2 centimeter diameter of a point, 1 centimeter above the crossing of the inferior thyroid artery and the RLN. Inferior glands have a more variable position, and they are often present below the artery level or within 1 centimeter of the lower pole of the thyroid gland. Sometimes ectopic or supernumerary glands may be present. Hypothyroidism is one of the most common and serious complications from thyroid and parathyroid surgery, resulting from direct trauma to the parathyroid glands, devascularization of the glands, or removal of the glands during surgery. Hypocalcemia is initially asymptomatic in most cases, and the clinical manifestations can occur between 1 to 7 days after surgery. These clinical manifestations result from increased neuromuscular excitability caused by low levels of ionized calcium. And if it is not present, the patient may develop potentially life-threatening manifestations such as carpopedal spasm, tetanic seizures, laryngeal spasm, etc. For bedside evaluation, we used Vostek sign and Trozios sign in all the patients. Thyroidectomy is a commonly performed surgery in the department of ENT, so an attempt has been made to evaluate the post-thyroidectomy hypocalcemia, its clinical features and management. Aims and objectives to evaluate post-thyroidectomy hypocalcemia in relation to the type of thyroid surgery, and to study the clinical presentation of post-thyroidectomy hypocalcemia and its management. Place of study was Assam Medical College and Hospital, Dibrugarh. Duration was 1 year, and it was a hospital-based prospective study. There were 74 cases in total. Inclusion criteria: patients of both genders who are to be admitted and positively diagnosed as having thyroid swellings requiring thyroidectomy and willing for surgery. Exclusion criteria: previously operated or irradiated patients, concomitant parathyroid diseases, complications which cannot be attributed to surgery due to natural course of the disease, and patients already on calcium supplementation. Proper ethical clearance was taken for this study. Methods: 2 ml of blood was collected pre-operatively for analysis of serum calcium and albumin. Another sample collected at 48 hours and results were analyzed. The clinical presentations of the post-thyroidectomy patients, if any, were studied, and those found hypocalcemic were managed accordingly. After discharge, patients were followed up on 14th post-operative day and then at 2 months, and at each visit, blood sample was collected for assessing hypocalcemia. Results and observation: gender distribution, the male-female ratio was 1:4.7. The most affected age group was 41 to 50 years, 29.79% of the total. 42 of 74 cases were diagnosed as colloid goiter. Hemithyroidectomy was most commonly done operation, which was done in 52 cases out of the total 74 cases. The commonest complication was hypocalcemia, which was seen in 17 cases, out of which 13 were transient and 4 were permanent. 12 out of the 13 transient hypocalcemic cases were females, and 3 out of permanent hypocalcemic cases were females. So in total, 15 cases were females. Post-operative hypocalcemia was more commonly associated with bilateral thyroid diseases. In fact, 16 out of the total 17 cases, in 16 out of 17 cases, the surgery done was bilateral surgery. Coming to the hypocalcemia cases, among the transient hypocalcemic cases, it was most commonly seen in 41 to 50 years of age group. And in case of permanent hypocalcemic cases, there were 4 cases, 1 in each 31 to 40, 41 to 50, 51 to 60, and 71 to 80 years of age. Most number of hypocalcemia cases were seen following subtotal thyroidectomy, but it was total thyroidectomy that showed 100% post-operative hypocalcemia. 4 total thyroidectomy was done, out of which all 4 cases showed hypocalcemia. We have 17 cases of hypocalcemia at 48 hours post-operatively, which reduced to 7 cases at 2 weeks and 4 cases at 2 months after surgery. The most common clinical feature was paresthesia of hands and feet, which was seen in all the 17 cases of hypocalcemia. 11 cases showed serum calcium level between 7 to 8 milligram per dl, which were treated with oral calcium, and 6 cases level was less than 7 milligram per dl, which was treated with IV calcium. 17 cases were found to have hypocalcemia after 48 hours of undergoing surgery, with management being oral calcium with vitamin D or IV calcium gluconate, depending on the level of serum calcium level, but at 2 weeks and 2 months, cases were managed by oral calcium, 500 milligram thrice daily, and vitamin D. 2 cases came with previous history of hypothyroidism and 1 case with hyperthyroidism, but all the cases were made euthyroid prior to surgery. Coming to the summary, the results and observations of all the cases in the study have been presented and compared with the finding of other literature. Incidence of age range from 14 years to 72 years, with maximum patients in 41 to 50 year age group. Male-female ratio was 1:4.7. Most common surgery was hemithyroidectomy. Certain postoperative complications, hematoma, wound site infection, etc. occurred postoperatively within the study period. Paralysis of RLN occurred. Also SLN occurred in 1 case, in 2 cases each. Hypothyroidism was present in 6.76% of all the cases. However, the most common complication following thyroid surgery was found to be hypocalcemia, which was seen in 22.97% of all the cases. Post-operative hypocalcemia was predominantly noticed after bilateral lobe surgery. Maximum number of cases were seen following subtotal thyroidectomy. However, it was total thyroidectomy that showed 100% post-operative hypocalcemia. All the 17 cases had hypocalcemia at 48 hours, but on following up, it reduced to 7 cases at 2 weeks and then to 4 cases at 2 months. The most common symptoms were paresthesia of hands and feet, which was present in all the cases. Oral calcium and vitamin D supplementation was given in 11 cases, and intravenous calcium gluconate infusion was given in 6 of these cases. Thus, from the study, we can summarize that hypocalcemia is the most common postoperative complication after a thyroid surgery, presenting clinically, which can be managed with regular follow-up and calcium supplement. Conclusion, in the study it was found that the thyroid nodule patients after being operated presented with hypocalcemia as the most common complication. On following up the postoperative hypocalcemia cases at 48 hours, 2 weeks and 2 months after the surgery, the number was found to decrease with time. Most of the patients had temporary hypocalcemia who recovered subsequently with medication. Oral calcium with vitamin D supplementation sufficed in most of the cases, whereas in the remaining cases, intravenous calcium gluconate was infused as per management protocol. A good preoperative workout followed by careful handling of the tissues and watchful dissection around the parathyroid glands during surgery can lessen the incidence of post-operative hypocalcemia. Regular monitoring for detecting early signs of hypocalcemia after surgery is necessary for effective management. A few intraoperative scenes where we can see this is the parathyroid gland identified. So it is an intra video where we can see this is the parathyroid gland being identified and dissected. This is what we are following currently in our department in consultation with endocrinology department. So post-operatively, we monitor the trosiosign bedside, and we also monitor the fasting calcium, phosphorus, magnesium and albumin level. If the trosiosign is positive, we give IV calcium 5 ampoules in 500 ml of NS in over 5 hours. And once it becomes negative, we stop it and start oral calcium with or without calcitriol supplementation. And if the trosiosign is negative, we directly give oral calcium. Maximum dose that can be given is tablet calcium is 4 grams per day. For tablet calcitriol, it is 2 grams per day. Sometimes if requirement is very high, we can add injection teriparatide. The take-home message is that it is not enough to only save the parathyroid glands during thyroid surgery, but to save the glands along with its blood supply, which is more important. These are the bibliographies. Thank you.
Thank you, Dr. Rejana, for your nice presentation. The hypocalcemia is nowadays very, very common, especially after thyroid surgery. And to prevent the hypocalcemia, our surgeons should be careful. And if we become careful, then such incidence of hypocalcemia will definitely go down. Here, in this LH Hiranandini paper 2, I like to pay my tribute to Hiranandini sir. Hiranandini sir was very close to me. I met him for the first time at the Nebaoicon, fourth Nebaoicon at Imphal with Professor Siddhas sir. We were in the same hotel where he was staying there, and he used to call my daughter Dr. Jayanti as his own Betty. And I had the opportunity to visit his residence twice. He was a great donor. Everything has been told by my previous chairperson. He was a great donor. In context of Northeast, I like to mention here that Dr. Jaman invited Hiranandini sir to Itanagar. Yeah. Then, at the end of the conference, Dr. Jaman has gave him the air ticket. So, at the end of the conference, he refunded the air ticket and added some other amounts, a large amount, and that amount has been transferred to our parent body. And through that amount, the Hiranandini PG Award is given. With these few words, I give a tribute to Hiranandini sir.
I request the chairpersons to honor Rizwana.
I call upon Dr. Gautam Khand to felicitate the chairpersons.
Next up we have our SN Sharma PG Award paper. The chairpersons are Dr. Rupali Saikia Fukan and Dr. PK Soikia.
Dr. Rupali Saikia is not available amongst us, so I asked Professor Dr. Anjali Barua to take over the chair, and Dr. PK Saikia. Suklima, please come over to the dais.
The speaker for SN Sharma PG Award paper is Dr. Suklima Sengupta on the topic Quick Identification and Preservation of Facial Nerve using only posterior belly of digastric muscle.
Good morning all. Let me introduce Dr. S.N. Sharma. As you have seen that his name is in the line of LS1 and LS2 and then S.N. Sharma Award. Dr. S.N. Sharma was contemporary of Dr. L.S. Hiranandini. He was the teacher of our teachers. He was head of the department of ENT in Assam Medical College. Then he was the founder principal of Guwahati Medical College. He also wrote the college song of Guwahati Medical College. He was pioneer in head and neck surgery in Northeast. He did even total laryngectomy in 5th and 6th decade at Assam Medical College. He was a great person, great teacher, and this award is going in his name. That is Dr. S.N. Sharma Award.
I am Dr. Anjali. I feel privileged to chair this session. Our speaker is Dr. Shuklima Sengupta. She is second year PCT, ENT, Silchar Medical College Hospital. Her guide is Dr. Kripamoy Nath sir, and she has He has passed her MBBS from North Bengal Medical College Hospital, Darjeeling. Okay, you can start your
Hello.
deliberation.
A very good morning, respected chairperson, faculties and all delegates present here. I am Dr. Shuklima Sengupta, second year postgraduate trainee from Silchar Medical College. I am highly grateful and thankful to the organizing team, judges and Nebaoicon for choosing my paper for the prestigious S.N. Sharma Award. My paper topic is Quick Identification and Preservation of Facial Nerve using only the posterior belly of digastric muscle. So coming to the introduction, parotid glands are the largest salivary glands, as we all know, encapsulated and divided into superficial and a smaller deep lobe by neurovascular plane of facial nerve, superficial and transverse temporal arteries and veins. Parotid surgery like superficial or total parotidectomy are considered as the best treatment modalities for different types of tumors, such as pleomorphic adenoma, Orthin's tumor, mucoepidermal carcinoma, adenocystic carcinomas, squamous cell carcinomas. And there are various key indicators to locate the anatomical landmarks of the facial nerve. It can be in the anterograde manner or in the retrograde manner. Along with that, there are other methods also like nerve monitoring microscopes, gamma probes for identification of the nerve. And preserving the facial nerve trunk along with all its terminal branches is highly essential in any parotid surgery to prevent the facial disfigurement, emotional stress of the patient suffering from the palsy. So the aim and objective of my study was to identify and preserve the facial nerve trunk quickly along with all its terminal branches using only the posterior belly of digastric muscle assisted with microscope during parotid surgery. In the materials and methods, it was a hospital-based prospective observational study in Silchar Medical College for a period of 1 year. Patient with parotid lesions requiring surgery who attended Department of ENT was the study sample. The sample size was calculated using the Daniel formula with the prevalence of parotid disease in India taken as 5% came out to be 19. The inclusion criteria were all the parotid gland diseases requiring parotid surgery who attended Department of ENT and gave consent for the study. And exclusion criteria were patient having large volume tumors with fixity to the underlying structures and patient requiring revision surgeries and who received radiotherapy were excluded from the study. Coming to the method of data collection, detailed history, clinical examination was recorded as per the proforma and informed consent. Relevant investigations like ultrasonography, FNSE, CT scans were recorded. Superficial or total parotidectomy was performed as per requirement. The surgical technique include, after proper general anesthesia and exposure, modified Blair's incision followed by elevation of the flap, identification and preservation of the posterior belly of greater auricular nerve, then identifying the posterior belly of the digastric muscle, and thereafter approaching anteromedially to locate the facial nerve trunk, followed by tracing all its terminal branches. Data like distance from the facial nerve trunk from the posterior belly of digastric muscle, time taken to locate it was recorded intraoperatively. Patients were analyzed immediate post-op, at discharge and after 1 month post-surgery with their histopathological reports. Surgeon satisfaction levels with this procedure were also taken into account. Coming to results, among 19 patients, female to male ratio was 12:7. Next, coming to distribution of different parotid diseases we got was mucoepidermoid carcinoma was only 2, that is 10.52%. Pleomorphic adenoma was the maximum with 12 patients, that is 16.15%. Simple epithelial cyst in 10.5%. Squamous cell carcinoma is just 1 patient, 5.26%. And Warthin's tumor in 2, that is 10.52%. This slide shows the different images of the diseases we got, like pleomorphic adenoma, Warthin's tumor, and squamous cell carcinoma. Next, coming to the age distribution. First, we can see that pleomorphic adenoma, which was more around 31 to 40 years. Next is the simple epithelial cyst, which was found in less than 30 years. Third is the mucoepidermoid carcinoma, which has a bimodal distribution, 41 to 50 or more than 60 years. Then is the Warthin's tumor, which was found in 41 to 60 years. Squamous cell carcinoma was found in above 60 years. From this, we got that mean age of presentation was around 44 years. Coming to surgical event and outcome, a total of 5 patients underwent total parotidectomy and 14 patients underwent superficial parotidectomy. And facial nerve trunk was preserved adequately in 16 out of 19 cases. Only 3 patients suffered facial nerve paresis following the surgery. 2 of them had injury to the marginal mandibular nerve and only 1 suffered difficulty in eye closure. We can see these 2 images, image 4, intraoperative image, where we can see that greater auricular nerve along with both the branches are quite well preserved, along with the facial nerve trunk and all its branches. In the image 2, we can see the black arrow which represents the posterior belly of the digastric muscle, and the green arrow shows the facial nerve trunk. Now coming to locating the facial nerve trunk, about 10 to 15 minutes was required in 16% cases, 15 to 20 minutes in 32% cases, 20 to 25 minutes in 26% cases, and more than 25 minutes in 26% cases. Thus, the mean time to identify the facial nerve trunk was around 21.78 minutes, and the total operative time ranged from 60 to 150 minutes. Next, coming to the distance, a less than 5 millimeter was found in 5%, 5.5 to 6 millimeter was found in 16%, 6 to 6.5 millimeter in 42%, 6.5 to 7 millimeter in 16%, and more than 7 millimeter was found in 21%. Thus, the average distance of the facial nerve trunk from the anterior border of the posterior belly of digastric muscle was calculated to be around 6.44 millimeter. In this image, this is just the anatomical picture where we can see the sternocleidomastoid muscle, the fibers of the posterior belly of digastric, and the facial nerve trunk emerging from the foramen and going forward. With this instrument, that is vernier caliper, we measured the distance. In this image, we can see the black arrow represents the posterior belly of digastric, the green arrow facial nerve trunk, and this is the distance. So here coming 2 images that no other complications of parotid surgery like flap necrosis, sialosis, or salivary fistula was found postoperatively on week 4. Coming to the discussion, facial nerve trunk exits from the stylomastoid foramen and travels for a shorter distance of approximately 13 millimeter and enters into the parotid gland. It divides into the upper zygomatic-temporal and lower cervico-marginal branches. The facial nerve trunk and its terminal branches are so intimately related with the parotid gland that they are highly prone for the injury during the surgery, causing the facial nerve paresis. Thus, both the trunk, terminal branches along with their interconnection, pes anserinus, must be preserved to prevent the permanent aesthetic sequel as well as medico-legal issues arising from it. There are various ways to identify, as we have talked, anterograde matter or retrograde matter, or using nerve monitors, gamma probe stimulators, but in this study we have just discussed the commonest and the easiest and quickest way to identify as well as preserve it. The anatomical knowledge and the position and direction of the fibers of the posterior belly of digastric muscle that lies medial to the sternocleidomastoid is required. The facial nerve trunk lies approximately 0.5 centimeter deep to the medial attachment of the posterior belly of the digastric muscle to the digastric groove of the mastoid tip, which is easily identifiable by drawing a line from the mastoid tip along the posterior belly of the digastric muscle to the styloid process, which correspond to other published literature also. And in this study, the average distance of the facial nerve trunk from the anterior border of the posterior belly of digastrics was calculated around 6.44 millimeter, with an average time to identify it was 21.78 minutes. Whereas the distance of the facial nerve trunk from the tragal pointer, if considered, is approximately 13 millimeter, which is much larger than what will we get from the posterior belly of digastric, which is more difficult to locate due to a drawback of the tragal pointer being a mobile, asymmetric, cartilaginous structure with blunt and irregular tip. The surgeons are also completely satisfied in prompt identification and preservation of the facial nerve trunk and its terminal branches, using only the posterior belly of digastric muscle as a robust indicator. Coming to conclusion from the above study, it is revealed that a good anatomical knowledge with fine surgical skills and expertise are true treasures for protecting the delicate facial nerve and forbid any facial disfigurement. Quick exposure of the posterior belly of digastric muscle, followed by locating the facial nerve trunk just anteromedial to it to the anterior border of the muscle at an approximate distance of 6.5 millimeter can be done with an approximate time of 20 to 22 minutes from the skin incision, followed by identification of the terminal branches pes ansorinus anterogately assisted with microscope can help preserve all the branches of the facial nerve. So my references, thank you. And I'm highly grateful to Dr. Kripama Nath sir, Associate Professor, Department of ENT, for guiding me throughout this project. Thank you.
Hello, Dr. Shuklima.
Yes,
you
ma'am.
have very nicely presented your paper,
Thank you.
vividly described about facial nerve location and also about the time taken to identify the facial nerve. So it's a very nice research paper, I think. Congratulations, Dr. Shuklima.
Thank you, ma'am.
Thank you, Dr. Suklima. Nice presentation. Usually there are other methods to identify the facial nerve like tragal pointer.
Yes,
We
sir.
senior people usually we use this method
Yes, sir.
as it is going on for a long time.
Yes, sir.
And this is a method also sometimes people use, and I think it is also useful. And let's try this method. Thank you.
Thank you, sir.
And this session is over.
May I, Dr. Suklima Sengupta, to kindly proceed towards the felicitation corner, and may I request the chairpersons to kindly felicitate her. May I request the organizing committee to take the memento. Now may I request Professor Dr. Priya Sakhi Devi to kindly come forward and felicitate our chairpersons.
Now we shall begin with our invited talk session. The chairpersons are Dr. Tilak Bhattacharjee, Dr. H. Mohan, Dr. Bani Chakravarti, and Dr. Nicola C. Lindo. Unfortunately, Dr. Ashok Das couldn't make it to this invited talk. Our first talk is by Dr. Nitshore Morangtham on the topic endoscopic transoral cervical osteophyte excision for dysphagia.
A very good morning, ladies and gentlemen, and I would like to welcome every one of you to Neboi 2024. On behalf of Neboi, I thank the organizing committee to give me this opportunity to look on surgery which is easy and very easily accessible, but hardly done. We as an ENT surgeon, we are redefining our boundaries where we can reach. So, sorry.
I would like to introduce first, actually, Mr. Dr. Nitishar. He will be presenting the endoscopic tension cervical osteopathic excision for dysphagia. This is an invited talk. As you know, he's a very renowned surgeon in the Northeast, very dynamic, and he is doing very nice work in Manipur and in the Northeastern region, and holding the post in the Nebai office bearers. He is doing so great service. I just request him to start the talk.
Sir.
Thank you.
Thank you so much. So I'm sorry for that. I started in between. So the picture, please. Yes. So as I was telling, we ENT surgeons, we are redefining our scope of our interventions that we can do from our side. Previously it was from dura to pleura. Now it has become up to the vertebral body, and then anteriorly to the skin. So everybody is redefining, and part of it is what I would like to show is a very simple procedure. But if you have the right attitude and the right anatomical knowledge, I think we can do it without much difficulty. So in this one, today I'm going to present endoscopic transoral cervical osteophyte, which is causing a dysphagia and airway obstruction to middle-aged and older individuals. Yep. So this 55-year male presented with slowly progressive dysphagia and difficulty in breathing, and he had got a history of CBA also before. He has got generalized weakness and inspiratory stridor, which are slowly progressive over time. So in this patient, we had to be very careful because he already had a CBA. We don't want to give too much pressure over that one also, and also we don't want to give too much of had to go through difficulty in breathing and hypopnea, and that could again aggravate his CVA status also. So in this, we did a 70-degree endoscopy with simple that tool we have, and here we can see the osteophyte closing the airway. See, the epiglottis collapse during inspiration. Yeah. So the epiglottis collapse during every inspiration. So in such cases, I think they are going to change. Is it okay? No, volume is okay. Volume is okay. Yeah, so we did an X-ray, and then we see this osteophyte, and we did CT scan, and in the CT scan we see this thickened osteophyte up to the level of the larynx, up to T4. So in our perspective, up to T4 we can easily assess. We can easily assess in the sense not with the your conventional thing, but by using our angle scopes, like we have 45 degree, 30 degree, 70 degree, using those scopes we can assess this area. And in this patient, actually he had got a very prominent one here. So this was blocking the thing, and the lower part, it's not that much giving much hindrance, but I have got another one also, another CT where the extension is much more in this one. So in the few cases that we did, it is extensive. The real size of the vertebra is up to from here to here. So in such patients, we could also anticipate some cervical instability. So the surgery that we are going to have to be a little on the softer side. We cannot put too much pressure on there. And as we plan the surgery, the simplest thing we do was to document it using an endoscope, the intraoral. So in the intraoral, when we do the endoscope, we see this this obstruction. See, the endotracheal intubation was done quite difficultly, and in this, since we have this elevation, one thing I would like to stress in this part is, if we maintain a midline position, there is hardly any injuries to the muscles, to the vessel, and to the nerves, because this area directly exposes the vertebra. So if we stay in the midline, it is in the midline raphe, and it's a relatively avascular space, so we can proceed in this one. And also, when we proceed it has got certain advantages also. So as we proceed, we want bloodless fill for proper identification. So I was cutting the mucosa with a mono, and then see the muscles here. These are the prevertebral muscle, the longus colli, and the capitis will be little away. So using a simple forceps, a curved forceps, we see the osteophyte. We see the cervical osteophyte that is obstructing the, and we can use a simple elevator, a phrase elevator that we all have in our OTs. We can expose this area behind the I would say our fascia. And then the first thing we do is we access the superior part. The superior part is easily accessible with the drill, with the straight scope. Our more problem starts lying in the inferior part. So this part we have already removed it and we have decompressed it, but this part is lying. So for here, if you see the tip of that burr, you can easily identify it is the same, the angle burr that Storz has, sorry, Medtronic has. So we were using this instead of the debrider blade, the tip, we have the burrs. So here we have got 15 degree blade and 70 degree blade. So we can use both these blades to induce or to drill that area. But this debrider blade itself is quite, it's not very hard, it's not very strong. So we have that, opportunity to use this. And then bits by bits we started removing, and then bits by bits we started, drilling. So in certain cases, we see the decompression starting to come up, but this part is still lagging behind. So this is the bone that was behind. So here we are using 70 degree scope. So this part again, we used chisel, but then it shouldn't be hard because it could cause destabilization of the cervical vertebra. So we fractured it, we go slowly by slowly, we fractured it, and then we remove this chunk, this piece of bone. And then after removing this is the cervical disc part, and this is more kind of a softer consistency than the bone. Again here, this part of the bone also we use our chisel, the curved chisel actually, not the straight chisel. Straight we cannot reach this area, so we use the curved chisel. But with this, slowly and slowly we remove this the elevated part, the osteophyte, and then this part, the lower part is remaining. So this part we wanted to remove with the chisel, but the chisel was not reaching. So we keep on, we try with the chisel, so we keep on using this 70 degree, the Medtronic drill, to drill this area slowly by slowly as we are seeing it. It's good that, relatively bloodless fill, so not much difficulty with using it except the handling of the instruments. So we remove piece by piece, drill a little bit, remove it, do an Excel kind of exploration, and then remove piece by piece. So after removing all these pieces, what we find, we can wash this area again. Still little bit of the remaining. As we go lower and lower, the difficulty level actually arises. So in the beginning, we should be more confined with the C1, C2, and even C3. But then as we proceed forward, we can continue with using the the more angle scope and the more angle blades. So here also we are doing something kind of an Excel drilling. we drill only the medial part or the posterior part, and the upper part is left behind. This, when we remove this part, it will become easily, we can easily fracture with any instrument, any curved instrument that we have got. So this is actually, and then here we are using this forceps. If you identify, it's nothing but giraffe frontal forceps. Any instrument, whatever angled instrument that you have, you can use it. There is no specific criteria that this instrument can be used or this instrument cannot be used according to your criteria. Now, now, previously how was it, and now after removing of this osteophyte, we see the airway, the endotracheal tube so open. See, previously this area was completely filled up. Now this is all open. So this is a direct approach. The most important thing is this is direct approach. Now to help with the hemostasis, we put surgery cell and wait for some time. We can use bone wax, we can use cautery, we can use many other things. And this is the final picture after the proper hemostasis has been achieved, and we just stitch it with a 3-0 or 2-0 bicryl. One thing I found here is when you give the stitch, please take a little bigger, because in this case we took a little smaller, so there was one case of wound dehiscence because this area is quite mobile, during swallowing every time it moves. So if you take a little bit bigger stitch, then the chances of dehiscence will be much lesser. So this is what the preoperative look is, and this is what the postoperative looks is. And this brings to the end of my presentation. Thank you so much.
I see. Thank you. Thank you, Dr. Nitishya. What the yeah, continue. You can continue.
Sir.
Yeah, very nice presentation, very daring surgeon.
Sir.
In fact, we have done osteophyte surgery, but we did not do the transoral route. We did cervical.
Yes.
But do you work without a neurosurgeon?
No, in this case, I consulted and I took help of my orthopedic surgeon, sir.
Okay, it's
Orthopedic,
fine. Both of them do the spine.
Yes.
But the way I saw you handling the chisel, not only it's the direction would be difficult, then with the mouth open, with the mouth gag.
Sir.
Did you not get a lot of problem negotiating the drill and the chisel?
Sir, in the beginning only I used the straight one. And the later part of in the second half of the surgery, we always use the curved one. So in that curved one, there is two cases actually. Even if with the curved one, if you keep it directly in the midline, it's difficult to reach in that area.
Right.
So we took the chisel from the side, so at the angle of the mouth, and from there we can reach that area.
Very nice, very interesting.
Yeah, it's a very actually excellent surgery, but I still just few questions for you, very important one.
Sir.
Have you used any diamond drill to uniformize the bones there?
Exactly, sir. The drill, the whole time we were using is diamond drill.
Okay, that's one
Yeah,
is nice.
yes,
You said that there are 2 degree
Yes, sir, we use the 15, first in the beginning we use 15 degree, and
Yes.
as we proceed more inferiorly, we use 70 degree.
Yes, and then how many days you keep him in not in oral food to heal it up?
The patient actually was admitted already in the ICU. So the patient, because of his severe status, so the patient was again shifted to ICU, and later the decannulation process and all is the same as any other patient with intubation in ICU.
Yeah. Have you faced particularly in this patient?
Sir.
Have you faced any difficulty regarding any neurological part or any other part?
Not exactly, sir. Not exactly, because why we were using this drill is to prevent any type of pressure over the vertebra. So in certain types, there are reports of instability where they use the plates to screw it up. But then in this case, since it's a drill, we don't put any pressure, so there's nothing of that sort of complication that we see.
Postoperatively, any difficulty in swallowing reflex?
No, sir. No, sir. There's not much, because swallowing is mostly from the posterior part. That area is only used as a transit.
Okay. Okay, that's
it's relatively immobile area.
Yeah.
So thank you, Dr. Niteshwar.
Madam.
One of the, I think you are one of the very, very brave ENT surgeons, from orbital decompression to facial decompression to retrograde tracheal, what was that paper last year in Nebaoicon, and now this very, I should say, is an achievement.
Thank you.
And
Thank you, ma'am.
we are proud of you.
Thank you so much, ma'am.
Thank you.
We are proud that I'm your student.
How many cases you have done?
Sir, I've done 3 cases till now.
3 cases.
Sir.
Result?
The result is almost same. It's just removal of the obstruction. Once the obstruction is relieved, the problem is relieved.
Okay.
So,
Nitin, your presentation is really good.
Sir.
It is, I am really mesmerized. But one thing was striking in my mind.
Sir.
That since you are going downwards, though you are changing the angle of the scope and all,
sir.
But then the visibility was not that good. And number 2, when you are using chisel to operate, there is a possibility of cervical destabilization, and moreover opening into the canal itself, vertebral canal. That danger is always there. And moreover, when you go for this thing, you have taken help of orthopedic spine, but then the fixation of the vertebra comes into account when there is a destabilization.
Exactly.
So lot of risks you have taken, but you have done successfully. That is something great.
Sir.
And you are example for all of us.
Thank you so much, sir. Thank you so much. Sir, with Drymon, you control your depth so easily. Yeah, but with cutting, a sudden jerk, and because since it's a small space, we have to manipulate many instruments. If you use cutting and sudden jerk, it may drill much deeper. So just to avoid that one, I want to go surface by layer, surface by surface, and then assess it and then go further if there is still a problem there. So the surface. Yes, of course, sir, with the proper irrigation also.
Thank you, Dr. Niteshwar.
Thank you so much.
Thank you, Dr. Niteshwar Morankam, for your wonderful presentation. Next up, we have the next talk session by Dr. Biswajit Gogoi on the topic relearning tracheostomy.
So thank you. We would like to welcome Dr. Biswajit Gogoi to the stage and to present his subject, relearning tracheostomy. Dr. Biswajit Gogoi is again another daring and brave surgeon, one of the pioneers, I think, in the Northeast. The youngest, Niteshwar and him have been side by side, I think, trying to compete in the OT. But anyway, we are also very proud of you, and we are proud to have you here with us. You can please start.
Very good morning. Thank you, ma'am, for the kind words, and respected my teachers, and thank you, organizing committee of Nebaoicon 2024, for giving me opportunity. Most probably, I'll be stay here for next back-to-back 1 hour. Thank you so much. Topic of my today's presentation is tracheostomy, my new learning. Most probably, this is a very recent learning of last 2 or 3 years. I have a post-graduation of almost 15 years plus, but these are learning I'm going to share with most probably 2 or 3 years or maximum 5 years of my experience. But if you ask any ENT otolaryngologist, have you done any airway surgery? I think yes, everyone has done the airway surgery. So If you see, the 80% of our airway walk starts from tracheostomy, and most probably also ends on tracheostomy. So that's my learning. And recently, I confuse sometimes in my post-op note, is it tracheostomy or it was a tracheotomy? So this is a diagram I follow by heart. It's in the Philip Monier book. There's a 3 sides, ABC. I'll not go details, but most probably this, through these slides, through picture, my learning will grow. So what are my new learning? The number 1, the Zorc flap. Number 2, maceration sutures. Number 3, the complications. 2 complications I want to highlight today. A-form deformity, suprastomal collapse. Number 4, decannulation is not a one-day issue. It's a momentary things. It's a process. And how will you know the tube size? So Zorc flap. So if you see the picture, I'll not go to details about the surgical things. The Zorc flap basically is the inferiorly placed flap where we just reflex the one cartilage and we tie with the suture. What is the advantage of Zorc flap? It prevents accidental decannulation. It prevents suprastomal collapse. It prevents emphysema if the patient is a post-ventilatory. And most importantly, that's why I put in the first word, that's not STOMY, it's the TOMY. We have not sacrificed any cartilage. Okay, sir. So this is inferiorly based flap. Is my coming? No. This is my inferiorly based. We have not sacrificed the cartilage. We have just backing this flap, we rotate this, the cartilage superiorly. So this is the advantage of Zorc flap. And I'll share the video how we'll take the Zorc flap. And this is the maceration suture. Initially, we just put suture. One is superior aspect, one is inferior aspect. So that if there's any accidental decannulation, that suture helps. But nowadays, we make suture. If you see, there's a 3, superiorly there are 3 suture, inferiorly there are 3 sutures. It may not be 3, we can make it 2 also. That's how you can measure the suture. And what is the advantage of this? This is how we can go for the Zorc flap. This is a conventional. And another important thing, now most of our tracheostomy, we take the help of anesthesiologist, whatever the crisis is there, because we have lots of supraglottic airway things are coming. They can sedate in pediatric, both the pediatric and adult age group, and we can do very comfortably. It's not like that we are doing crisis tracheostomy. So very, they are not paralyzed the patients, and bipolar I think is a key in today's tracheostomy. So you can see we are not doing any cartilage surgery, we make a horizontal incision, and then after that we take a suture to pivot the flap, and most importantly, we have a, this video is not clear here. Can you picture there are 2 vertical incision over the cartilage. So that's then we put the sutures. So it's a combine of 2 things. One is your flap, number 2 is your maceration suture. That's how if the child or the adult also decannulate in the first hour or second hour, then our paramedics can easily put the tracheostomy tube. It is not required the tracheal holder or anything else. You have a patent tracheostoma. But issue is that it mostly depends upon what is the etiology of tracheostomy. These are the mostly cases where you need a long-standing tracheostomy. We are going for intervention. We want to keep the tracheostomy for a few days. And this is how we make the sutures. So this is very briefly my 2 learning. One is a Zorc and one is a maceration flap. What was my 3rd learning? Was a suprastomal collapse. Just have a look this 2 video. So how will you know the suprastomal collapse? This child was tracheostomized long back. Now we have a plan for decannulation. Then when we did the scopy, When you remove the tracheostoma, he had again crisis. It's difficult to decannulate the sile. So in that situation, it is always advisable to go have do a flexible scopy and just remove the tube, tracheostomy tube, and have a look at the suprastomal part. Then you can appreciate this mass of collapse is there. So this is called suprastomal collapse. So I am playing again. Can you appreciate this is the superior speck of the tracheostome, which is collapsing, in fact, during full inspiration also. So this is the cases where we put the, particularly in the pediatric age group, when trachea is more meliatic, and we have put the tracheostomy tube for a long period, maybe more than 6 weeks, maybe more than 100 weeks, who have also associated malnutrition and other associated comorbidity. So that's this, because this sile is a growing sile. They will take the shape of the, what is the curvature of the tracheostomy tube, and that's where they begets meliatic. So suprastomal collapse, again, how to prevent. That's why I'm from right and left, I'm going to concise my whole thing to the one point. Again, the Zork flap. Again, you need a maceration suture. So, but here is one key, here is this slide. I think Niteshwar can appreciate. Can you appreciate here? The neck skin suture to the Zork flap inferior around the tracheal, that's okay. This is very important. The width of the flap, should not be larger than the length to obtain square opening. That's the key here. So this is the key here, so that we have to choose the proper tracheostomy tubes, and also the incision is very important. So another complication of tracheostomy is a A-form deformity. Just have a look. What is the form of our tracheostomy? It's a C-shape. Why we have a C-shape? Why it is C-shape? Why it is not circular? Because that's why it's absent posteriorly, so that esophageal, during swallowing, the anterior esophageal valves move forward and allow the food to go down. That's one thing. And also, in all animals, it's a complete thing, except the human, to prevent tracheomalacia. But this A-form deformity, if you see, this C-shape becomes A now. Can you, this is a slow motion, because after decannulation, this patient has an exertional dyspnea. What is the complaint? He had an exertional dyspnea. He had no other issue, but when he go for jogging, when he go for brisk walking, he has some kind of, if otherwise is a respiratory and cardiac, all things are normal. Then when you evaluate, because he was a post-intubated, long-standing on tracheostoma, then when we found that his a few segment of his trachea is a A-shape. So prevent the A-shape, that's why, again comes the width of the incision. That's very important. So that the size of the tracheostomy does not give a compression, so that it like a more lateral movement on every time. So it does not get, that's why two meliatic, one is anterior, posterior, superior, inferior, one is lateral. If you see very simply, one tracheostomy is causing superior, inferior problem, one is causing lateral problem. Well, that's why superior, inferior, suprastomal collapse, lateral problem is a A-form deformity. That's all. I think these two complications, my learning, I know many of people have know all these things. Last, my learning, the decannulation. Decannulation is a process. We know from our great teacher, the first learning was downsizing. Next is the capping. The capping, he has to tolerate the full capping. What is the capping? We have always a 4-quadrant capping. I have learned it from Dilip Barua sir. 1/4, next half, then 3/4, then full capping. Now we have learned in the pediatric age group, you need a full capping. You have to do, nowadays they also advise sleep study with a full capping, and daytime speaking valve, especially during, you have to admit, we generally admit the child, and also flexible endoscopy is must for decannulation. What we want to see? We want to see the vocal fold movement. We want to see the suprastomal collapse. What is the exact stomal side, and also the lower airway. Fish is very important, and at least observe the decannulation, because we are losing one cell. We sent him, he was very good during our hospital stay, but he collapsed after 3 months when he has a crisis. So ultimately the surgical closure. So this is very important, and the original condition, why you have to take that should be you have to have a thorough study. It was a longer ventilation state, and we have to look for clinically stable optimal airway. No fissures are at that plan that make effect. So any unplanned emergency tracheostomy should be considered as a mismanagement of compromised airway. He is by Kishore Sandhu. So these are my last. You have to know the proper size of the tracheostomy tube. We have a very good Cincinnati card. Please go to the card. I think no new Android has not these facilities available. You know that's why what is the size of the ear required. I welcome hereby everyone to more know my teacher Kishore Sandhu from Switzerland. I have learned lots from him. Please join and let's have a few. It's not like big airway surgery. This is a very basic thing. I have learned all these things when I do tracheostomy, but we can't decannulate the cell. What is the problem? We blame others. You have a problem with cardio, you have a problem with respiratory, but let's have a look our way. Thank you so much again for giving me the opportunity. Thank you so much.
Thank you, Dr. Biswajit. Now the house is open for questions.
How do you manage a suprastomal collapse?
It's very easy for you. It's very easy for you. I know. It's very easy for that's why I'm telling you. You see, this is a collapse. This is a collapse. So why this is a collapse? Because this cartilage is falling down, that suprastomal way. You take it as a hook. Put the scope, take a hook, see how much collapse is there. And just again make a flap. That's all. It's written in the book also. Misong, I had a negaya. Don't ask tough questions.
No, sir, never. This first picture, it looks like granuloma also.
Yeah, you are right.
How would you differentiate this is granuloma or collapse?
Thank you for your question. I love this kind of granuloma. Now it is airway managed very well. Look, what we now recently, this is also new learning. This is a learning from Mike Rutter from Cincinnati. Nebulization, that's the simple thing. You nebulize with a ciprofloxacin dexamethasone eardrop, number 1. I can share the formula, how you give. It's a nebulization. And also, if it is a very big granuloma, then you can also go for office Kanakot injection also. We have a granuloma office Kanakot injection. You can't imagine, subsided in the next 2 weeks, almost enough. You can do in office also. But that's why sometimes it requires swab data. You can take a tracheal swab also.
Yes, Bishop, what is the recurrent chance?
What is recurrent, sir? This is granuloma.
Yeah, after the treatment, what is the recurrent chance of this granuloma?
Granuloma?
Yeah.
In our experience, I don't know exactly. One shot, sir. One shot, but we also the continuation of exuberant this the ciprofloxacin and dexa. This is on paper. This nebulization for at least 4 to 6 weeks. This is on paper. I can share the materials also. How they do nebulization.
Yes. After that, there is no recurrence.
No. I have in our. I have a granuloma. I have the video also, but no.
Okay. Thank you.
If I can add to your answer.
Every abdominal also, sir. In case of post-tracheostomy also, there is stand related. We use Montgomery tube. Then there is in the superior end, there is some, because of the movement, there is some granuloma. We have a patient from Nagaland. He have a big granuloma. We excise the granuloma, then we again continue it. Because sometimes big granuloma, it required excision because air is not maintaining. You can do it either. We have a no CO2 laser, so we direct laser only, and we excise the granuloma, interlesional canal cord. Very good, that's interlesional canal cord. Lots of studies are there, and continuation of the.
What we have seen, in case of granuloma, there is lots of recurrence chance. So what should we have?
So yeah, I think that sense you go for the tracheal culture, do a CS, rule out the organisms.
Let me answer. Let me add to what he is asking, because the situation Dr. Newton is talking about is when you have a tracheostomy. No, you are unable to decannulate. If you are keeping the tracheostomy, because of the friction, the granulation can come back. And secondly, as you said, if the hygienic standards are not good, you can have secondary infection in the tracheostomal site, which can also lead to granulation formation. And another point is, many people listening to this talk might be thinking that I have done so many tracheostomies, I have not seen A-frame deformities, because A-frame deformities in an adult, when you have done a vertical incision, taken out cartilage, may not be so obvious because the patient will compensate if he has got a large airway. But the problem is with the child.
Yeah, so, the growing cell, basically growing cell. Mostly it is the issue with the growing cell.
So your all these cases that you've got are mainly pediatric airway cases.
That's
that is
growing cell, pediatric age group and growing cell. Yeah.
And what is the age of this child? What is the age of this child?
So this is mostly 4 or 6 years. I forget exactly.
Okay.
4 or 6.
All right. Do you give this Canacort injection before you try for tracheotomy?
No, ma'am.
You don't
do
it.
No.
Okay. You go
But if the presence of granuloma or any suspicion lesson, that's why. But nowadays the swab culture in before any like a laryngotical reconstruction and all these surgeries nowadays advisable. And also if you have the tracheostomy was done long back, and you have to see the stomal site culture is also very important. Let's the sterile, then you go for the reconstructive surgery.
Okay, thank you.
Can you wind up this session, Chairperson?
Thank you, ma'am. Thank you once again.
May I request Dr. Biswajit Gogoi to kindly proceed towards our felicitation corner.
Thank you, Dr. Biswajit.
Thank you, sir.
It was a very nice presentation. We enjoyed it actually. Thank you again.
Thank you.
May I also request Dr. Niteshwar Moirangtham to also proceed towards our felicitation corner. And may I request our chairpersons to kindly felicitate our two speakers. Felicitation. Dr. Biswajit Gogoi and Dr. Niteshwar Moirangtham are being felicitated now by our honored chairpersons. May I request Professor Dr. H.P. Soikia ma'am to kindly come forward and felicitate our chairpersons.
Now we have our airway panel on the topic laryngotracheal stenosis, the roadmap for management. The moderator is Dr. Gautam Khaun, and our panelists includes Professor Dr. Rupanjita Sangma, Dr. Bishwajit Gogoi, Dr. Niteshwar Morangtham, Dr. Keshavanan Kuar, and Dr. Monmayuri Fatwale.
Tea stall is outside. If anyone want to have, you can go and have. But our program will continue.
Good morning, everyone, and thank you to the organizers of Nebaoicon 2024. It's a great feeling coming to Sivsagar again after 2 decades for a Nebaoicon, though we keep on meeting each other. And may I ask the panelists to kindly come over to the stage. Dr. Monmayuri is the anesthesia person in this panel. Dr. Kesavanan Kaur from Sivsagar, Dr. Rupanjita Sangma, Professor of Assam Medical College, Dr. Niteshwar, and our tracheostomy guy, Bishwajit Gogoi. Please. So, please. So this is our esteemed panel. We have got 4 ENT specialists and 1 anesthesia doctor here. And this is a small appeal to the panelists. Please try to be very specific and brief, because we have got 45 minutes in which we have to give some messages to the audience. And please don't be repetitive. If somebody has given an answer, please don't be offended if I interrupt you at any time. And for the audience, if you have any queries, please jot it down and pass it to us. That will save time, because we need to finish in 45 minutes. So to take the subject forward, we all know about the different etiologies of LTS. It could be due to trauma, which can be blunt or internal. It could be post-radiotherapy. It could be due to burns, due to chronic inflammatory diseases, benign disorders, malignancies, and others. And see, we have such a vast range of things which can happen. I'd like to know from all of the panelists, one by one, very quickly, what is your personal experience, I mean, in your centers, what is the sort of incidence of, not in really in percentage, of LTS that you get to see, and what are the different types of causes that you commonly see? We can start with Rupanjita, yeah. And somebody please tell me 10 minutes before the time. Yes.
So I would start with the causes, regarding the causes. So the most commonest cause that we get for a tracheal stenosis is prolonged intubation.
Okay.
Mostly it is prolonged intubation or maybe faulty technique of tracheostomy. So these two are commonest that we are getting.
Yeah. Niteshwar, in your place?
Yes, the same thing as Madam said. And also, after this, some trauma kind of thing in so trauma, post-trauma, and even after post-tracheostomy also, the suprastomal collapse is also one of the main, reason for
reasons
this.
of presentation.
Yes.
Okay. Dr. Monmayuri,
Ma'am have already answered the things. The most common thing is the prolonged intubation.
Prolonged intubation, post-intubation.
Yes.
And from the more experience, because Kesav has been into airway work from much before.
So what we have found, particularly if I talk about our present scenario in our hospital, I have found one case, means it's one case in terms of a faulty technique of tracheostomy. Because of that, it happened. So tracheostomy was done in our hospital itself, but it was not done by me. So because of that, he had. Otherwise, whatever patients I have found is mostly prolonged intubation. On even certain cases are there which are not even cases of prolonged intubation, but
Right.
maybe some crash intubation or kind of things.
Yeah,
that
yeah. It need not be prolonged intubation most of the time. It could be a short duration of intubation, but badly intubated. We will come to those points later. Biswajit.
In our set of adult post-intubation and trauma, pediatric, not that much of cases, but one who have a congenital subglottisness.
Right. So this was an interesting paper published a long time ago, 2014, by AIIMS Delhi, where they incidentally found more of blunt neck trauma as the highest cause. But that is a center-specific study maybe. And when we were discussing in Trivandrum, I mean the year before last year in the Phonocon, it was interesting to note in South they get a huge number of, apart from post-intubation, they get a lot of organophosphorus poisoning related, which we don't see as much. We see organophosphorus poisoning occasionally with more of esophageal problems, more of aerodigestic, but they get in airways as well. Well, that will be a center-specific maybe. So what happens really, this is for the beginners, for the young people, intubation-related injuries, you have ischemic necrosis, pressure necrosis, you have mucosal ulcers and inflammation, and there is fibrosis and the sequelae. In external trauma, there is disruption of the cartilage framework, there is hematoma formation, mucosal disruption again, and there is fibrosis. In chemical burns, you can have mucosal or even deeper injuries, inflammatory changes, and ultimately the end result is cicatrization. So with these points, let us come to some case scenarios so we can discuss much more easily about the problems of LTS, because the cases could be very different in some situations. There is a 15-year-old girl who suffered a gunshot injury to the neck while fiddling with her father's loaded gun, and she was intubated, was in the ICU for a month, then extubated and discharged, and comes back after 3 months with 3 weeks with a respiratory difficulty. I think our anesthesia colleague will agree that most of the patients post-intubation who come to us go home after the ICU stay very happily, breathing properly. So when such a patient presents to the your say emergency, what is your next step?
So first, if the patient is from our if the patient is from our hospital, she came back, then I will assess her. I'll see physically. I will see if she has any stridor and all. Then later on assessment, we'll go for this fiber optic intubation, bronchoscopy. Then by that we can see the length, or we can assess the size of the stenosis and all. Then further, if it is there, then I will call Keshav sir.
Yeah, naturally. So I think for Niteshwar or Biswajit or even Keshav, when a patient presents to your accident and emergency, your junior will probably call you, but in a medical college where Rupanjita is practicing, say a child or an adult, or if it is 15-year-old girl presents, I think you are not the first person who sees. It will be seen in the extended. So what would be, if they call you up, what would be your advice? What do you ask the people to do?
15-year-old, first we would of course like to assess what is the degree of obstruction. So, and what is the status of the patient? I mean, how much stridor is the patient presenting with? Depending on that, we'll take the next step that we plan.
Right.
So, if the stridor is like the patient is having frank stridor, so definitely we'll have to go for a tracheostomy before we do any assessment. I think that is the thing we'll need to do, assessing the breathing difficulty there, so to say.
Nitesh sir, what would you like to add? Thank you.
Sir, the simplest is let's separate it in a pediatric as well as adult. In an adult, it's simple. The patient, 15 years old. So in such individual, the first thing we do is at physical examination. How is the progress?
Right.
Whether it's a slow progress, fast progress. Fast progress, it could be something else. But if it's slowly progressive, in due course of time, then a simple auscultation, examination of the oral. Because here again, why examination of the oral is because we have to distinguish whether it's a flutter type of obstruction, whether stridor or whether wheezing type of, because all the segment has got different sounds.
Right.
So that would also teach us where to look for specifically. And another thing is we need to assess how much the hypoxia has affected the individual, because that will determine our speed of intervention, whether we want to.
Yeah, that is for general, but this child has a history of intubation and is coming to you, so you probably have a vague idea in your head that this is the area where the narrowing should be. So you also would, if the patient is not in a crisis, you would go for an assessment.
Exactly.
So,
exactly.
Keshav, what is your ideal sort of way you go ahead?
Since we know about the history of the child, the patient, it's already there. It's 3 weeks time. After 3 weeks of time, patient has come to with a stridor, with a respiratory distress. Usually, post-intubational, they develop this stridor within 2 weeks of time, and if initially they ignore, if this is just a 1 week, so I don't think that will be that much of a crisis at that time. If that child is not at that crisis, stabilize, pre-oxygenate, do a ABG immediately, because ABG will tell us the hypoxic injury, what is happening over with the child, instead of going straight away for any other further evaluation. Because we know the history is there, we are expecting a tracheal stenosis. So go for ABG and we'll do pre-oxygenate and do one nebulization with adrenaline, so that the edema subsides immediately. And with that, within one nebulization, the child is almost near normal. Then we can go for assessment further.
Right. So Biswajit, let's make it more complicated. Now the child is in a stridor. You want to give her an immediate relief. Now you are in Sipsagar and your junior has to do the tracheostomy. Where will he or she do the tracheostomy? How will you assess? I mean, we are assuming now that because this is a post-intubation tracheal narrowing at some point, or maybe a subglottic narrowing, we don't know, because we are unable to assess the child is in a stridor, the young girl is in a stridor. Now you need to do a tracheostomy. What would be your advice?
So if you ask today's scenario in our setup, definitely I'm agree with Keshav whatever he does. Now is a very specifically a point of tracheostomy. If there is an urgency of tracheostomy, definitely I'll ask the to gather the team, in essence on me also, the junior team, gather all the peoples, the anesthesiologists, if it is a pediatric case group, a pediatric intervention nursery, and shift the patient to the OR. But before putting the track, at least have a look the stenosis, if it possible, because as Keshav says, what is she is required? She is required number one, oxygen. So how will you first facilitate oxygen? Manage conservatively. Put adrenaline nebulization, body cord nebulization. You see, if he's maintained the saturation, then we have enough time. This patient is rushed for at least 3 to 4 hours, and he's not in crisis. This patient has every chances of you can put a scope. Keep ready everything for tech. I'm not telling that you for the scope you utilize your time, but let's have a scope. Put a needle. In pediatric case group, I'm not agree with Keshav. I'll not do my ABG in non-OR room, non-heady. I'll do ABG in a OR where he's a little sedated or little, because that also causes exertion and they have a more distress. And now if you put a tube that this is the site of the stenosis, then I'll go for the tracheostomy, but I'll ask them to do the tracheostomy at the site of stenosis. But practically speaking, can I give tips here? To do a tracheostomy at the site of stenosis, you need one instrument. That is a very good bipolar, and if you have a bipolar with a cutting and coagulation, because that is a fibrotic area, that is an inflamed area, there's a lots of blood during this tracheostomy. Keep ready. It's not easy to do a tracheostomy at the site of stenosis. Theoretically it is right, but practically we have seen bleeding, and very difficult to skeletonize trachea, to retract the step muscles and all these things. It is always easy to do a tracheostomy in a virgin area, non-stenosis area.
I agreed with you. And one more tip, actually, sometimes when the child or an adult presents to us with a stridor in the OPD, even verbal reassurance, apart from all the things that we are going to do, nebulization or oxygenation or steroid injections, even verbal reassurance that you are not going to die, you are going to survive, breathe slowly, helps a lot in calming down the patient, and you buy time. And you buy time before you actually plan for a definitive. So this is the video of now everybody has agreed to do a scopy if the child is okay. So this is what the scopy says. So after the scopy, Nitesh sir, what is your further take? What would you like to do? Any more investigations? This is what you see when you put in a flexible scope.
Yes, sir. The first and foremost important is what is the length of the the whole stenos part.
Yeah.
First assessment is very, very important, because without knowing the length, you cannot plan the further front. So first length, and then also to see whether how much tracheal injury has happened or not.
Right.
Along with the cartilage, whether it's associated with the cartilage or with this, whether it is associated without the cartilage. If it's associated with the cartilage, then
to know get all these answers, yes. What is your investigation of choice?
CT we can do this one in further with TFNL. We can also see there is label there in the TFNL that shows the exact distance of that area.
Right.
We can do the CT also.
Yes, please add on.
CT, but exactly not the CT of the neck or something like this. We will have to do exactly the CT scan of the airway, that too of the thin length.
Pediatric age group, CT scan not going to give the length of the stenosis because
right.
the cartilage is not developed.
I know, Mr. is going to say that. Yeah.
Seriously speaking, I am not with the CT.
No,
because how the cartilage...
not talking about...
And this is
15 years almost pediatric,
So
because it's very difficult to, because cartilage is not fully ossified. It's the length of the, it is very difficult sometimes. And lower age group, it is no rule of CT. But if you want to, if it's a grade 3 stenosis, suppose, you can't negotiate the scope. And if you're going to negotiate the scope, he'll be in the crisis. In that scenario, that's why OR setup, you have to do a rigid scopy in the OR. There's a very good photograph, youngster, the scope, it required actually bronchoscope, that we have at a 2.9 bronchoscope. Then you can, with the 2.9 scope, you go distal part of the scope, mark it, then come proximally, mark it, then this give you the exact length of your stenosis. That's where we can measure the actual length of distance.
No, Rupanji, let us assume that the length of the stenosis has been determined as just 1 or 2 rings, and it's 3 weeks post-intubation, post-discharge, the patient is present to us. So with this information in place, what would be your treatment of choice? What would be your
I think
take?
the best option depends on the size of the stenosis also.
Right.
If it is up to 75% is obstructed, then up to 75% I think it is okay if we go for dilatation. But if it is beyond 75%, then of course I think we'll have to go for a definitive surgery, that is resection. But this one looks less than 75%, so I think dilatation would be good enough.
Yes,
sir. I agree with this. We can go for balloon dilatation first, 1 or 2 sittings.
Right. So actually,
excuse me, Gautam, can I make a point?
Yes, please.
So this is from our experience. I am telling what Biswa has said. In a 18 years baby, CT scan will really help you, because we have done in a few cases. Because if you do not assess the extent of stenosis after doing tracheostomy, if the patient doesn't get relief of the distress, you are at a loss. And second point is that you need to involve your anesthesia team with you always, because you will get a lot of help from the anesthesia team from every point of view. But assessment of the stenotic point or the stenotic segment is very important before going for a tracheostomy.
Another point is they don't give contrast in a distressed patient.
Yeah.
That's another big issue. If you don't give the contrast, then very difficult to differentiate between the secretion.
With the high resolution technique in the CT scan advancement,
Yes.
you will get the idea.
That
If you
is
communicate,
I think CT scan gives a good
if you can
view
communicate
of
with the radiologist,
Sure.
you will get an idea.
Trachea. We've been doing CT scan and it shows.
Adult is okay, ma'am.
Yeah, even in pediatric age, not pediatric, this is 15. So I think we can, get the.
We are missing a radiologist in the panel today.
Yeah, we should have had one.
We can actually correlate the endoscopic and the radiological findings together. If that matches, that will be plus
Only
minus
one
2 millimeter.
investigation cannot definitely tell you everything, so we definitely need to correlate. And Biswajit also has a point. Yes, we had trouble actually trying to assess because most of the time we work together. So in assessing. But having said that, high resolution CT scans can give you some idea regarding the soft tissue shadows, etc. And
sir, in our first subglottic stenosis cases referred by Khan sir, that was a case of subglottic stenosis. And radiologist has this is a report by the radiologist, but actually he has a bilateral abductor palsy. His both cords are abducted. There is a secretion in the subglottis. Whole secretion was there. So he referred me as a Bishop, have a look, it's a subglottis, and then we have found it's a Mohanta. He has a bilateral abductor palsy. This is a real scenario.
Anyway, we talked about this slide, you need to stabilize, etc. So everybody has agreed we need to assess the cause, the degree and the site, and then accordingly plan your management and your planning, whether it is direct surgical or an open surgical or a non-surgical. But at the same time, you also need to know about your capabilities, your capability of your center, and whether you have the proper instrumentation. Just diving into the water without knowing how to swim is not going to really help you. So this is, as Kesavananda Kaur said, this is the same child where Biswajit actually tried balloon dilatation, in fact twice if I am not wrong, isn't it?
But
So
we have a failure.
Very short, quick words about balloon dilatation. Because we used to use the various dilators, the Savary-Miller dilators and the Foley's catheter, the endotracheal tubes for dilating. Now we have got dedicated Indian-made airway dilators, airway balloons by Merrill, which are not very costly and very useful as well.
Yes, sir. Yeah. Regarding the balloon dilatation, nowadays FDA has approved balloon dilation for the trachea. Initially, it was not approved for the trachea, only esophageal balloon dilation was there. Now, Boston Surgical have the balloon dilation, and this is, I think, the Merrill. And in this case, we have, as I had, because the only indication for balloon dilation, we have a very specific indication for balloon dilation. That's what the specific indication. It should be a short segment. That means it should be a very thin segment, either one segment or two segment. It should be, it's not a chronic stenosis, not more than 6 weeks. It's a recent stenosis. And that's why endoscopic evaluation is very important. That is, it should be soft stenosis, exactly. Soft stenosis, mucosa should be healthy. So in that case, it should not be multiple stenosis. But if you see why we have a failure here, it is, and also the grade of this stenosis. It's a grade 3, as Madam has says. It's the indicated case of balloon, but there's a high chances of failure of balloon stenosis in grade 3. Why? And it is also has a, if you see the endoscopy first, is a multiple.
Grade 3 cotton mare.
Yeah, cotton
there
mare.
are many gradings. In
Yeah,
cotton mare,
yeah.
grade 3 would go up to 90%.
Yeah, that's
so that you cannot go for.
There's a very difficulty for this.
In fact, that is why I have put a question mark for grade 3. Maybe without a balloon, you can try dilatation with a bougie, and then try go in with a balloon. That is a possibility. Now, this child was dilated twice or thrice, I don't remember exactly.
Twice we have done.
Twice, yeah. And then
maximum we can do thrice.
Yeah, but then she came back again with the stenosis. It comes back to the same, almost same position. So, what would you do next?
This would be surgical intervention, of course.
So, everybody agrees that we
Resection.
go for a surgical resection and anastomosis.
In one of the papers I read, is there any role of, this is a question for, role of mitomycin in stenosis? Has anybody used?
Initially,
I
yes,
got
ma'am.
it in a publication.
Initially, yes, mitomycin,
Yes.
but nowadays mitomycin is not
Long back
advisable.
I read that paper.
But what is the exuberant therapy with the balloon dilatation? Actually, that was our first learning case actually. That day we are not using the Canaccord. But nowadays, along with the balloon dilatation, we always interlational Canaccord. But when? Before the dilatation or after the dilatation? Many people, Cincinnati group, they advocate before the dilatation, before the balloon dilatation, so the drug distributed very well. Some opinion has a after the dilatation, but we are doing mostly after the dilatation.
This is just for people who don't know that this is the way we used to dilate before balloons came up. We used to use the endotracheal tube also, and this is one of the persons who came up to almost 50% reduction, and he's managing with that. He works in a bank. Anyway, that we will pass on to a different case now. We will talk about resection anastomosis here. This is a 30-year-old male, one of our very early cases, RTA, ICU stay, intubated, later tracheostomized, and tracheostomy could not be closed after 6 months. Now, we have all agreed that we will do a scopy, and this is what the scopy says. Kesav, I think you were also there with this case, I don't know, because we worked together at the one point of time. So, sorry. Yeah. So this is the scopy of this patient. Diagnosis?
It is grade 4 almost.
So
There is no airway almost.
And your treatment now?
It's just establish the airway first.
Yeah.
And then
The tracheostomy is already done. The patient is come with a tracheostomy to you.
So we'll go for the surgery, sir.
So we will go for surgery. And what surgery would you do?
The segment, the segment is it's almost we'll go for complete cricotracheal resection.
Yeah, this is where actually sometimes we have a very difficult situation of making a decision whether it will be a tracheal resection anastomosis or whether you have to include the cricoid or not. What is your take?
We go for tracheal resection and anastomosis because the subglottis looks clear to me.
Biswajit, would you like to add something here? This is the controversial part because sometimes what looks like a tracheal may not be just tracheal, it could be a little bit of a subglottis.
Yes, absolutely. This is a take home for the juniors people. In my learning was every stenosis was a tracheal stenosis. So I do only the cut the tracheal part and do the stenosis. Then I have seen that there is a re-stenosis because I have not touched the cricoid. If you see the stenosis started from the just started from the low down the cricoid, then how will you anastomosis? Either at the low end of the cricoid with the trachea, but the cricoid is a complete ring. How will you do stitching of the cricoid and trachea?
At least 2 rings of tracheal cartilage should be free.
Yeah, then here is not, sir. Yes, this is the problem. So it depends upon how will you manage. It depends upon I will open surgical procedure. I will open the lesions. Then I will see. Then I will say what is the cricoid status? How is it involved? What is the posterior aspect of the cricoid? If it is involved, then most probably I will go for resection of the part of the partial cricoid and preserve the mucosa. Then I will do a cricotracheal reconstruction. So take home is that. Not there, tracheal stenosis should be repaired with a tracheal anastomosis if the cricoid, have a look on cricoid. And here, what's a great learning from like Professor Kesu Sandhu, try to preserve as much mucosa from the subglottis because you ultimately required mucosa to stitch.
Mucosa is going everywhere, be it the ear, be it
the nose,
trachea.
be it the trachea, everywhere. Preserve the mucosa.
Rupanjita, actually the answer is obvious, but these are the points that you look for in LTS. Would you like to add something here? I mean, this is obvious. We look for the site of stenosis, the degree of the LTS, as everybody has said, the length that has been discussed, distance from the vocal cords. We'll look at the vocal cord movements, etc. Would you like to see anything else? We also like to see the tracheal mucosa, and for that maybe we do the look at the undersurface of the trachea because the tracheal mucosa needs to be healthy.
Retrograde, of course, if the patient is tracheostomized, then we can go for a retrograde tracheoscopy, so to say. I think.
So, starting with you, now you have planned to do a resection anastomosis in this patient, and what are the challenges? Maybe one of the surgeons can tell us one challenge in this resection anastomosis.
To be frank, I haven't done an end-to-end anastomosis, but yes, of course, the stenos part has to be excised completely, otherwise again fibrosis will get in. And then end-to-end anastomosis, and then of course the position of the neck post-surgery is very important so that
Right.
it is maintained.
Right. Nita sir?
Sir, what I feel is more than the surgical difficulty, it's convincing the parents, the counseling the parents that is more difficult because you know such kind of patients may have recurrence in future and they may do a revision. Even cleaning part, since pediatric we may have to do under GA repeatedly again
Let's
and
assume
again.
that this is the adult
So,
I showed you.
Yes.
This
So
particular
counseling the parents is one of the most difficult things. Second thing is exactly the side of the stenosis to know which type of the methods that you can use. Third is whether there is any comorbidities. If there are comorbidities, then this one prognosis as well as the chances changes, the plan changes. The fifth one I would say is proper post-operative care is one of the most important thing.
Right. That's very important point, well taken, because proper post-operative care, but intraoperative, Keshav, something for the youngsters, somebody who wants to do a resection anastomosis, what are the things that they have to remember? 2 points from you, 2 points from maybe.
So in case if this is a fresh case, that is going to be not that much of a difficult thing because you will have a fresh good plane. But in terms of if it's a revision case, or it's if there was associated a neck injury at the time of the accident,
if you're expecting a lot of fibrosis,
so in that case, that to get the trachea out of without injuring any other structure is very difficult. So that is one great challenge.
Biswajit?
Number one, just a comorbidity is always like diabetes, malnutrition, any other this cardiac issue.
Right.
Second is the biggest challenge is that team-based anesthesiologists in the team because and also for the post-op care. Third is a stenting, and most important I think paisa, money, because they have already invested lots of money in the ICU care and all those things. Then post-op also they require money. So these are I think the most challenging, and Keshav has already uttered.
Intraoperative, what I also wanted to actually from you is that we have to save the two recurrent laryngeal nerves. That is very important because
and the vascularity also
yes,
as
we
much as
do
possible.
not actually try to see the recurrent laryngeal nerves unlike thyroid surgery here. We will try to take off the
decap the petechial fossa, lateralize it, let it fall down, and just elevate the trachea. Never try to have a look on the. But issue is that when you go for cricotracheal reconstruction, when you go for cricoarytenoid joint dissection, they don't go too much of lateral because the nerve is entering here. So that's how. And also the drops. The post of another challenge is that if you're going for drops means when you sacrifice a drop trachea, then you will go. Not go to this full drop or half drop. But when you drop, there's again the chances of aspiration. That's also challenge.
After resection anastomosis in midterm Nebaoicon in Shillong a few days ago, there was this professor from CMC Vellore who insisted that there should not be any stent inside, whereas in AIMS we always see almost that they put a Montgomery stent or something because the patient has to go far away. So Keshav, what is your take on stents? Do you like to, because you have been doing airway surgery from a long time, are you in favor of putting a stent after a resection anastomosis?
Not if the patient is on regular follow-up. If I feel that the patient is come from a very far away place,
right.
So I would like to put up a stent for certain time, say 1 year, 6 months to 1 year,
right.
Then reassess, because follow-up is much more important for that kind of patient.
I think all the others are also in agreement with that. So
not exactly 1 year. We generally call the patient after 3 months. Let's have, if this well healed, the stent is free. We do simple access of tissue neck. Then you see anterior column free, air column free, posterior air column free, and also the lateral. Then
that's what I'm trying to say. It's a long distance patient.
Yeah.
You cannot.
Suddenly he will end up with a psychiatrization again and with a respiratory difficulty, and he will not be able to come back. And as all the panelists have said, these are the important points in tracheal stenosis to look for the grade, the length, whether it is a soft or a hard stenosis. Look at the vocal cord mobility, the comorbidities that might be there, and etiology, because if it is a caustic burn or something like that, your whole prognosis changes, and the duration and radiology we all discussed. Suppose you have a post-op patient of PCTR maybe done in some other center or even in your center, and patient has some difficulty, little bit of difficulty in breathing, and you assess and you find something like this. Something like this. So what would you do? At the anastomotic site, you have got obviously a granulation. Yeah.
The most important finding we see is that fibrin and granulation. If that fibrin and granulation started appearing at approximately 10 days post-off, then start thinking like it's an anastomotic failure. So that is one thing, and in a proper anastomosis there should be either minimal or no that fibrinous deposits there. That is one thing. And second thing is when you have this one, we need to take a decision whether we need to open it immediately in a very short duration and re-anastomose to preserve that earlier anastomosis, or we need to wait for a longer period of time to see the progress, how it's progressing. But then when there is granulation tissue, it's always good to have a clean up in that area first, post-off.
Rupanjita, would you like to do some conservative measures before you go to open, because getting a consent to re-explore the neck would be again a difficult issue?
I think we can try with nebulization with steroids, since it looks like a granulation tissue.
Keshav, what's your take?
Go for intralesional steroid injections.
Yeah. Would you excise and put intralesional steroid, or you'll just put?
If it depends upon the size, the extent of stenosis.
Right.
If it's causing more than say 70%, but he will not improve with that single shot without removing.
Yeah. So this was actually excised and nebulized.
That's the I may agree with Keshav. If it depends upon the size of the granuloma, nebulize, we always try with a small lesion with a granuloma. But if you see here, there's a mostly stent was there, and we have the tracheostomy is there. A tracheostomy tube is there. So this is how we decannulate. We put the T tube. That's I have learned from Alak Taka sir. We remove the T tube. Then we always put a smaller size tube for at least 1 week or like 1 week. Because it's very difficult if you have anastomosis and a short neck is flexed, they can't do intubate for this kind of situation, because it's difficult to extend in a freshly.
Tracheostomy is there, so the airway is secure.
That's why we remove the tube, T tube, then always we put 5 size so that maintain the patency.
Yeah. I think we have got just around 10 minutes time left, so we'll quickly have 2 cases. So this is a 25-year-old man. Had a wire injury, because this is not a very uncommon injury. You are driving a bike and there's a wire in front of you, maybe which you did not see, and the wire hits your larynx. And this young man had a laryngeal cartilage fracture. He stayed in the ICU, came with a tracheostomy. Let's not go to the CT scan. And when they did the first copy, the patient with a CT scan, we found that the vocal cord movement was also restricted. There was a flicker of movement, and so I'm asking you the findings here. So this was the stenosis lower down, but as you can see, the vocal cord during examination are not moving. When he tries to phonate, there is a restriction of movement. We discussed here and there, and Devika started giving voice therapy, and we actually, so the history is not very long. So with that point, Nitesh, sir, would you straightway go for a surgery, resection? What is your plan now?
Sir, again, if it's not that long, then we can always try for balloon dilatation first. We can always, and of course, after this conservative of this steroid and nebulization and all. But if it's of a long course, long duration, then I would prefer to go for if it's very near to the cricotracheal resection, anastomosis, similar surgical. If it's long term, surgical. Short term, conservative most time.
Yeah. So
laryngeal injury.
Injury to the laryngeal cartilage, then intubated. So
post-intubation stenosis.
Because of the trauma, we assumed that because of the laryngeal fracture, the vocal cord paralysis was there, and then because of the intubation, you had a stenosis. So this patient, as you suggested, we went for a coblation excision of the scar and we injected. We did twice. The patient had to come from Upper Assam to Guwahati. So we said let's send the patient to Keshav. In fact, that is what happened. And in Keshav's place, he excised with the diode laser and injected, and the patient improved. So we were very sort of not very our thoughts were not very positive when we see that the vocal cord is not moving. Even if you do a resection anastomosis, if the vocal cord is not mobile, we cannot allow him to be off the Ryle's tube or things like that. So these sort of magics do happen. If the audio is playing, this was his voice. I don't know that. Voice to Solana. Anyway, his voice improved with time, and now he can speak in between. Before the last procedure, he was speaking. After immediately, he was speaking more with his false chord phonation, and now he's got almost a normal voice. So I will be a little fast here. One point I missed. Sorry, I wanted to ask our anesthesia colleague here when we talked about the challenges during the resection anastomosis, about the anesthesia challenge. Hello, about the anesthesia challenge, because you have a tracheostomy.
Yes, sir.
They go in for a surgery during the resection anastomosis, and now you need to take out the tracheostomy and you need to intubate.
Yes.
What do you do at this point of time? I mean, because the patient is on a tracheostomy, that's fine. They have excised the two ends. Now they want to oppose it. Now you have to take out the
Yes.
tracheostomy tube.
Yes.
So,
The
so at that time you need to do a peroral intubation.
Yes, sir. Sir, for that we will go. We used to do the bougie. We have airway exchange catheter. We used to have that. So while the tracheostomy tube is there, we use the airway exchange catheter, smallest size. Say for 5 millimeter, it's small. So we put that, and if the patient is, we put that and we assess for for a day or for say 4 to 6 hours. We used to assess. If the patient is comfortable with that, then we used to extubate the patient. Sometimes it's difficult. So if we can't extubate, then we will have to stay again for 1 or 2 days, and we will nebulize and all.
Right.
Then we used to do.
Actually, there are two things we learned from the AIMS group. One is to put in a tube in the beginning itself,
Yes.
up to the glottic level.
Yes.
Once this work is over and you take out the tube, you only have to push it down.
Yes,
You
yes.
did not take out the drapes and everything.
Yes.
And another challenge that I wanted to bring up is when you have all those sutures in place, your sutures tend to get mixed up, isn't it? So again, what I saw, I think Dr. Alok Thakur doing is when he takes the sutures, he puts a towel, then he takes another suture, puts it. So your sutures don't get mixed up. Otherwise, you have so many sutures, your sutures tend to get mixed up when you're pulling the two ends of the trachea together.
Usually, it's better to put a non-cuff ET tube.
Right.
Non-cuff
AAC is a non-cuffed only. It plays both the role. One, it gives oxygen, and the other it helps us.
Sorry, sir. Now, what we have found more challenging from the anesthesia and surgical point of view at one step. When suppose I am putting now going for a T tube. T tube upper end is
open. Yes.
But how will you ventilate? That's the most challenging now.
That one first, my first encounter with sir was that only Montgomery tube insertion. Then what we did was we used a smaller size tube.
Okay.
One in books we find that we can give oral packing and something, but there we immediately used the smallest size tube, maybe 5 mm ETT. We used that and we blocked the upper end.
Actually, that was the case of Pituitary, which that developed tracheostenosis. He was on a Montgomery.
Yeah.
So now a revision Pituitary had to be done.
Right.
So since the Montgomery upper end was open, he was ventilated through the Montgomery the T part. So
the
we put a smaller tube, smaller ET tube, and we blocked the tube from above. So we had
inflate the valve and you block the tube.
No, we blocked it from the upper end.
It was an uncuffed tube. We blocked the tube. We extended the upper end of the Montgomery. It's like just putting that ET tube
Hmm.
inside the Montgomery tube.
Got it. It's Indian Jugaad, basically.
Jugaad, that's
It's Indian Jugaad.
Sir,
So
nowadays we use LMA.
Yes,
If
LMA
LMA is
also,
also
No, LMA
LMA
can
has
also
also
be.
got a role.
okay, let's go to this last case. Nitesh sir or Rupanjita, anybody can take it. You are called to the ICU for a tracheostomy. The reason is inability to extubate. The history is very short. Only a week of endotracheal tube intubation. They are unable to extubate the child. And what would be your approach? This is what you see when you take the flexible scope in the OPD. Nowadays you have got all those mobile HubeMed. I think it costs about 5 lakhs. Very useful, very efficient, very good pictures, portable scope. And you see something like this. And remember, the history is only 1 week of intubation. So what would be your take? How do you go about it? Would you do a tracheostomy? You have been called to do a tracheostomy. You get your fees if you do a tracheostomy.
Sir, if the child is a case of a child or an adult?
No, you are called by the intensivist to do a tracheostomy in a young person, in a child basically. And you said that I'll do a scopy first before I do the tracheostomy. Why they are unable to extubate? And you see this thing, and the history is only 7 days of intubation.
Sir, we proceed with the conservative first. 7 days is too early for any decision on the surgical care.
So what would you do? Conservative?
Conservative.
What?
Dilatation.
Dilatation.
Yes.
Anything else?
And of course steroids.
In fact,
good antibiotic coverage also is very important, and using this ointment while using dilatation or whether granular tissue removal,
I think if I am not wrong, things like that, and I think improved it in a little bit of injections, isn't it? Kind of Kanakot injection. Actually, that brings us to the point of prevention, and I'd like to know from the anesthesia colleague here, Monmonji, to tell us what are the things in the ICU when you are running the ICU. It's not that you will intubate all patients.
No.
Your fellows, your juniors,
Yes.
sometimes even technicians may intubate a patient.
Yes, sir.
So what are your sort of, let us...
First and foremost is the size of the ETT, sir. If we use the smaller, that already mentioned, correct size of the ET tube, the smaller size is always better. Then the type of the tube, mostly reinforced tubes are used that can prevent, and the type the tube should always be of the low pressure high volume tube,
Right.
which gives the uniform pressure and that prevents the ischemia of the mucosal part.
Right.
Then the pressure, the cuff pressure,
Right.
every day we should assess the cuff pressure. Nowadays we have these manometers and all for measuring the cuff pressures. And the most atraumatic intubation, sir. Multiple attempts should be avoided. Then regular assessment of the early extubation is good, and if we can't, then we should do a tracheostomy within 7 to 10 days. And the patient age factors is always there. Extubation is always difficult in age in geriatric age groups. And
of course, there are some patients who definitely have tendency of scars.
Yes.
And yes, everybody can add in a little bit of points because we are running out of time. So correct size of the tube material is important. Keshav, you wanted to say something.
If the patient we are intubating, because the patient needs intubation or prolonged ventilation, so we must ensure that, as she said regarding the sizes of the tube, but we must ensure that the patient is not agitated while he is on ventilation. So we have to give appropriate sedation. The head movement should have to be, because in ICU there is a proper care.
Yes, that is one of the most
tube should
important
not be
points,
moved.
because the continuous movement of the neck when the patient is not fully paralyzed, it causes a lot of rubbing of this cuff of the tube against the tracheal walls, and that is one of the primary causes of injury, trauma, and ultimately cicatrization. And intubation, though in most cases it looks like a very easy, very fluid sort of thing, I think the learning process, even in the ICUs, because everybody wants to ILU intubate, so there should be a process of teaching people, letting people do the intubation step by step. One should not be allowing a novice to intubate and cause trauma. What is
most ideal place for intubation is OT.
Right.
And rest in ICU and ER every day we anticipate difficult airways. That's why.
So, Nitesh sir brought up the point, even Panjita or Nitesh sir can. These are the points are very important, which help to prevent intubation. I am happy to note actually, when we listen to the different talks in the all India level, in the national level, in our region, even though the number of ICUs have increased a lot, I think the care in the ICU is much better, because the incidence of tracheal or subglottic stenosis intubation related is not that high as we say in the general mainland India.
Yes.
That's my personal feeling, no studies, just a personal observation you can say.
Yes, sir. Regarding this prevention, of course, the first and foremost is the size of the tube, the duration of the tubing. Third is application of steroid and antibiotic ointment. It's done in some areas, it's not done in some areas. Some people use this plain Gylocan jelly also. In many areas I have seen not a single lubricants is used. Push it. It shouldn't be done. That causes more trauma. Steroid nebulization, of course, that will come only when your intubation failures and all are there, or if you are suspecting it. And local steroid injection. Now, this local steroid injection, I wouldn't recommend it daily, regularly, but in certain cases only. Little otherwise.
Right. And you talked about cuff manometry. Are you doing it regularly in your place? No. Any center? You two are in the same center, but
we have cup. Not this kind of. We have a simple pump. Cup.
Yeah. Please, one of you can just explain to the audience what is the leak test.
Very simple way.
What is the ideal endotracheal tube?
Very simple way. The leak test is after intubating the child, putting your and volume more than 10. Then if you see there's a bubbles in the surrounding that endotracheal tube, that the air is passing. So its leak test is positive. That's my learning. But otherwise you have to go the mathematical exam.
I had put up this slide because Biswajit's talk was just before. We are not going to discuss on tracheostomy anymore. We have discussed enough on tracheostomy, I think. Yeah, I did not get the warning, well, unfortunately. So the roadmap to LTS management is to manage the airway, find out the cause, plan the treatment and prevent complications, and always do not be shy to take help. In the first case that we saw, we tried twice and ultimately we sent it to Jyotirmoy Phukon to the resection anastomosis for logistic reasons, etc. And again, I'll repeat, please register for the Airway East 2024. It will be a great learning experience if you have any interest in airway. And just 1 minute before we end, any messages from the panelists, just one word each for the the new people who are here, the young people who are here, any messages, just one point each, just finish and we are closing.
Patience.
Thank you very much for your patient hearing.
Observation and patience.
All laryngotracheal stenosis are not tracheal stenosis. It's a cricotracheal stenosis also, laryngo and other stenosis also.
Thank you very much. Thank you for the panelists for your enthusiastic participation. Thank you.
I would now like to request our moderator and all the panelists to kindly come to the felicitation corner. I would like to request Dr. Obaidya Borgohai to kindly do the felicitation. Now we'll have our video session. The chairpersons are Dr. Nibaran Sharma and Dr. Bhavesh Das. Our first session is on ossiculoplasty with TORP by Dr. Arup Kakote.
Coming 6, 7, 8.
Sure, sure.
Good morning to all. Now we are going to start our video session. The video session time is 6 minutes and 2 minutes for interaction. So I request Dr. Orup Kakoti to start his video session with ossiculoplasty with TORP. He is assistant professor of Guwahati Medical College.
Sister.
This is a diagnosed case of CSM active squamous. a diagnosed case of CSIM active squamous cell variety with moderate conductive hearing loss, and HRCT shows gross ossicular erosion. So we are planning to go for mastoid exploration, post-auricular approach. It is a severely sclerosed mastoid. Antrum is deep-seated, and we find few oozing. It's probably slight dural bridge is there. We find few granulation tissue which is removed with the help of suction, curved prick, and curved forceps. We could not visualize any short process of incas. Middle ear cavity explored. It is almost total perforation. We find few colostomal flags. Removal done. It is a huge colostoma sac. After that, we start to elevate that tympanometal flap with the help of circular knife. We could not visualize any ossicular part. Coda tympani comes in view. Next we start a dichotomy. Next we start canaloplasty in the posterior aspect of bony canal. Inserts of pyramid and stapedius tendon. We only visualize the foot plate area of stapes. Now we are going to clear any disease from the editus region. We find few vertical colostoma which is cleared with section. Next we are removing the facial bridge area. We visualize a few eroded ossicular part. So these are probably part of body of incas. So after careful dissection, these two parts are removed. So we are planning to go for hearing reconstruction with torque. Teflon prosthesis. So this is the torque. We are placing a small piece of temporis fossa in the lower end after making a small hole. And it is placed in the foot plate area. So the temporis fossa below act as a cushion. So we put few gel foam for support. After that we place a small sliced about 0.5 millimeter thickness tracheal cartilage in the superior aspect of the prosthesis. So the prosthesis is stabilized below with the temporalis fossa cushion and above with the tracheal cartilage. So it helps in the future to prevent extrusion. After that we place a large temporalis fossa above the tracheal cartilage. A part of the fossa is also covering the mastoid cavity, which is partially obliterated. After that we place few gel foam above it and close are done. Thank you.
Thank you. Thank you for your presentation. So I request next.
Next presentation is by Dr. Anjan Jyoti Bhuya. He will present a video on stapedectomy surgery.
We can have the question and answer session right now, finish it because 2 minutes left. Any questions?
Then any question for 2 minutes.
Hello. Yeah, Rup, just one question. See, if you have broken the bridge, then why have you not removed the posterior buttress? The anterior and the posterior buttress. Any rationale of breaking the bridge but not lowering the ridge?
In this case, actually, we are planning to go for hearing reconstruction. So actually, we are just removing the bridge area, facial bridge area, so that the disease clearance is well dealt. Then after that, generally we in this video we due to the time constraint I edit few points. Actually, we done a reconstruction, slight reconstruction in the posterior superior aspect of the bony canal. So it is actually a partial obliteration of the mastoid cavity and intact canal mastoidectomy with hearing reconstruction.
So you actually reconstructed the atic.
Yeah,
okay.
Actually. Yeah, actually none. Patient shows improvement actually in postoperatively. Previously it is moderate. Now in the postoperative we assess after 3 months. It comes as a mild conductive hearing loss.
What is the quality of which make of pistons do you use? I mean,
Generally, this prosthesis is Teflon.
This is Teflon.
Teflon.
But have you used other qualities also?
Yeah, we are using also the cartilage. Tracheal cartilage can be used.
You are using torque.
Yeah, torque. Teflon. This is Teflon. Yeah. Thank you.
Our next session is on. Our next speaker is Dr. Anjan Jyoti Bhuya on stapedectomy.
Here I would like to announce that your participation certificate is ready in the reception counter. For delegates, we have able to achieve 3 credit point and for 4 credit points, and for faculty 3 credit points. Please collect your certificates.
May
I start? Respected chairpersons, my dear senior and junior colleagues. So, as we all do tympanomastoid surgery and tympanoplasty and all, so we are all potential stapes surgeons, because stapedotomy does not need more than, you need to be little more precise, little more patient, and little more perfect. So while doing stapedotomy, so our main concern, it's a very beautiful surgery. Our main concern is to is for the fenestration. Main concern is for the chorda and ossicular sense and all. So I do all my cases under local anesthesia. Sometimes with the mild serious or if the patient is a little apprehensive, I do local injections in 4 point in the canal with 1:2 lakhs adrenaline, and sometimes if the patient is young, then I can use 1:1 lakhs adrenaline. So I do a little cleaning in the external canal. So a proper fitting speculum is very much important, and you need to use a very sharp round knife. With that sharp knife, you need to go to the bone depth and give an incision 5 millimeter away from the annulus. Anteriorly, it should go a little more anteriorly, so that you can expose the ethic very clearly. So while doing so, you can use the both hand. Using both hand gives you a more visualization. And you can use a small cotton ball soaked with adrenaline, so that you can soak the blood from that area, and so that you can visualize that area beautifully. So it should be a very slow process. You should not break or it should not tear the flap. So after you identify the annulus, you retract the annulus, then you push the chorda tympani little downward, and then you start with the bony work. Anteriorly, we can go to the lateral process of the malleus. So while doing the bony work, we need a very sharp bone cutting curette. That curette should be used so that you don't injure the underlying ossicular structures, you don't injure the chorda tympani nerves. And if in this case likely there is you need to be a lot of curettes. So in such cases we can use a micro drill also. So micro drill help you to make your work little more faster. With the micro drill, we have, but while using micro drill, we need to be very cautious so that we don't go medially. So if you go medially, we can injure the chorda tympani nerve or the ossicular sense. So again, while using micro drill, there are a lot of dust particles are there. You need to be very careful to suck all the dust particles. So after the drilling and all, you will have to see the ossicular sense. We need to see the pyramidal eminence, and there should be adequate space for the instrument handling. That we need to re-establish the diagnosis by palpating the ossicular sense into the malleus, the incus, and the stapes bone. Need to identify the capsules, joint capsules, make an incision in the joint capsules, and dislocate the incotostapedial joint. After dislocation of the incotostapedial joint, we need to fracture the suprastructure. How we fracture? We push the suprastructure inferiorly, and with a little twisting movement, it can be fractured. But here, as you have seen in this case, it is not possible to fracture on the first go. So if you cannot fracture in the first go, there is a chance of breakage of the foot plate. So you will have to be very careful if there is no break and all. And ultimately it will break. Or otherwise, if you want to, if you have a assess of the advanced instrument like the laser and all, this will help you a lot. So while after cutting the stapedius tendon, we need to remove the stapes suprastructure. While removing the suprastructure, we need to be careful so that we don't injure any other structures. So in this again, we need to check the vestibule area. Need to understand the area where we need to give the prick. So for the fenestration, I use different size of the prick. In here, I am using to 3 millimeter, 0.3 millimeter, and 0.5 millimeter. And then after making the fenestration, I use a 0.6 millimeter of micro hand drill. So hand drill gives me a to make it a very fine fenestration. And with the hand drill, if I make the fenestration, that the fenestration is very round and all. So usually I measure the piston. It's a Teflon piston. and with a little push with a 90-degree hook, you can push the loop into the engage the loop in the with the long process of the incas. After engaging in, you need to push it down so that you are very sure that the piston is inside the vestibule, inside the fenestra. Or you can do a bend test by pushing the shaft of the piston so that it does not get slip. If it does not get slip, and at this point you can crimp the loop. After, the crimping should be adequate. It should not be too tight or it should not be too loose. So if it is too loose also, there is a chance of necrosis. If it is too tight also, there is chance of necrosis. At this point, we need to assess the hearing with some verbal questions to the patients. If we are satisfied, we are happy with the hearing, then we can come out safely by replacing the drum. So you can hand over this piece of bone to the patient, so he will remember for your life. Thank you.
Thank you, Dr. Anjanjoti Bhya.
Thank you.
Your videos nicely reflect your surgical sound and it is excellent. What about the post of hearing?
Post of hearing are excellent in this case, sir.
What about the non-operating hearing status of a non-operating ear?
So this is not an individual case. This is one of the case. But the thing is that in otosclerosis, most of the patient gets hearing on table. But the thing is that you will have to recheck it. You will be very vigilant for next few days or weeks, so that patient does not dip into a SN hearing loss. So that you can give the patients adequate rest, so that there is no leak. You can give steroids, and there is no immune related issues. So these things are there for the next few periods. But for me, I give 48 hours of complete bed rest. Though there is no leak, if there is leak, that is okay. If there is no leak also, I give a 48 hours of complete bed rest for the patient.
Thank you very much.
And in those patients, it is seen that the heart note also improves. But in the long run, I have seen many patients, they have some high frequency sensory hearing loss is seen. So that means maybe after 2 years, 3 years.
Thank you. Any question from audience?
Yes, sir.
Very nice video. You have saying that your step is the patient will remember for life, but actually by the hearing it will remember for life.
Two ways,
not
sir.
by the
Two
step
way.
is one.
Yes, sir. Two way. Two way of remembering you. One is if you give the hearing or if you destroy the hearing. Both way.
Anjan, your
Yes,
presentation is really good.
Thank you.
But one thing, when we are making the hole,
Yes.
be it 0.6, be it 0.5, whatever it may be,
Yes.
if you are using 0.8 millimeter piston diameter, in that case, some amount of space lies around at the area of the hole where you have created on the posterior part of the foot plate itself.
Yes.
And you may require some tissue graft right from the
Sometimes.
lobule and then seal over the area. What
Yes,
do you
sir.
think about it?
Right. You have rightly said. So there are two issues in where we need to discuss these things. Usually, what I do is I use a piston size of 0.6 millimeter diameter, and I use a drill bar. That is my normal protocol. I use a drill bar of 0.6 millimeter and a peak of 0.5 millimeter, maximum peak of 0.5 millimeter. So my maximum size of the piston is 0.6 millimeter. But sometimes what happens during the breaking of the superstructure, you may take out some part of the posterior part of the foot plate. So where you will find a big hole or large windows, then you need to put some grafting, ear lobules fat or some other fascias or the vein graft and all. These are necessary for if there is any leak, if there is a large gap, then it's necessary. Or otherwise, if there is no gap, no leak, it is not needed. I do. In the most of the cases, what I do, sir, in last many years, I have been using the piston with measuring and all. 4.25 is a very standard for me, and I do it. I put it 4.5. If I find little plus or minus, I have additional pistons in my hand, so I can give, because my pistons are not that costly also. But measuring is a good practice, sir. You should measure.
Another thing is that when you're seeing the mobility of the the level of the otosclerosis, mobility stapediovestibular joint.
Yes.
Okay, but then when we are finding that mobile is okay, then we have to press on the handle of the malleus also, so that the upper incado-malleal joint, if there is ankylosis, your whole purpose will be defeated. Because
Yes,
it
sir.
will not
Ye-
circle.
right,
so
sir.
we have to ensure that if you're pressing on the malleus itself, you get round window reflex. That
Yes,
is most
yes,
important.
yes, yes. You will have to say the whole continuity, and before breaking the suprastructure also, we will have to assess the malleus stability, malleus ankylosing.
Thank
Okay,
you.
Anjal,
Thank
that
you,
was a
Vajan.
beautiful presentation. Just
Maybe
one
Vishwa has
question.
got some yes.
Yeah, just me.
Yeah, yeah, okay. Yeah.
Okay, so just one question. Do you look into the cochlear reserve before doing a
Yes, yes,
stapedotomy?
yes,
And
yes.
what is the demarcation? What do you think? At
I-
what level do you think it will go well, and what level you think it
My
won't be that
criteria of
good?
taking up the patient is, it is minimum 30 decibel of AB gap. Though there is hearing loss, if there is 30 decibel of AB gap, then I take up this patient.
Anjan, excellent presentation, excellent videography, but a technical question. Why you have 80% your video is in the center, but why 20% sometimes it goes left, goes right? What is the tips to the junior how to put the speculum to this kind of surgery in the center?
It's not because only the speculum, because of my video editing and all, everything has got some issues.
Good. Anyway,
This is
thank
the
you.
issue, yeah,
Anyway,
yeah,
good.
yeah. But technicality you will have to learn from the Vishwa. Vishwa is the guru, and we are all learning from Vishwa for this technicality and all video presentation. Thank you.
Thank you so much.
Yeah, thank you.
Next presenter is Dr. Henry Nongram, transoral endoscopic odontodectomy.
Dr. Henry is absent from this session. Next up we have Dr. Keshavanand Kaur on transoral endoscopic odontoidectomy.
Transnasal excision of pituitary tumor.
My apologies. My apologies. Dr. Keshavanand Kaur is going to present a video on transnasal excision of pituitary tumor.
Good afternoon, chairpersons and all my seniors and delegates present here. So today I am going to present a short video about endoscopic pituitary excision. So this patient which presented to us with a short history of 7 to 10 days of isolated ptosis, one-sided ptosis and severe headache. Here, as we can see, the left eye, there is a ptosis with complete ophthalmoplegia, except for the lateral rectus movement, the eye is completely fixed. So on evaluation, we found that there was a pituitary adenoma over there, compressing. So here we can see the preparation for the surgery is as similar to any nasal surgery, any nasal sinus surgery. Apart from that, the flap which we take, it depends absolutely upon the availability of the septum over there. Like if there is a deviation, we prefer to take on the deviated sides. So that's why on this side here, the deviation is on the left side. So that's why we took on the flap over the left side, so that we can have a better access of the deviation as well to get it corrected away from the field. So this is how that flap is taken, this inferior and superior margins, and this is completely the flap has been taken out. And the next step is to take the cartilaginous part and the posterior septectomy. And with the debrider we can remove, once the flap has been positioned here on the opposite side, you can see on the left side the flap has been positioned over there in the choana, and here we see the sphenoid, the sphenoid rostrum of the sphenoid, and the opposite side, the flap on the opposite side, the mucosal flap has been debrided off, so that we get the enough space on that place. Instead of debridement, we can preserve that flap as well, but here we didn't found any need, so usually we practice to remove that. And complete posterior sectomy with a diamond drill, we can remove with a proper exposure of the anterior part of the sphenoid. We take out the keel, and now here we can see the anterior wall of the septum on both the sides of the sphenoid is completely taken out. This is the intersinus septum, which we can see here, which is not absolutely in the midline. So always we should never follow the intersinus septum, but we should always observe. We have to find the center, we should always follow this the keel over here, so that we are not lost, because you can see the keel is here and the septum is not in the midline, so it's deviated away from the midline. So that gives, so we have to smoothen out that intersinus septum. So once that has been taken care of, the posterior sphenoids we can see at the superiorly here on both the sides. This is not to be touched but completely exposed. And with since the because of the tumor, mostly the sellar bone over there is quite thinned out. So it's usually you can, with a gentle insertion of a Freer's elevator, you can easily break the bone. Once the bone is broken, we can take it out like just an eggshell crackling, and with this this Garrison punch, we have to widen out the sellar space so that we can have adequate entry into that. The idea, since in the CT scan we have seen there is some suprasellar extension of the tumor, so that's why the planum has been completely defined, so that if need arises, we have to go planum approach as well to take out the tumor. So once the dura is exposed completely, we do a bipolar over the dura, and with a simple sickle knife, or you can have an arachnoid knife, you can give a cruciate incision. Some people give a trapdoor incision, so we usually prefer to give a cruciate incision. So once it is exposed, you get to see the tumor bulging out of the incision. Initially is to take few pieces of biopsies to confirm, because biopsy is needed. So once biopsy is taken out, then we can do simple curettage, and suction curettage is usually the tumors are very friable, soft, so usually it is easily comes out with gentle suction and curettage. So here you see the tumor anteriorly has been cleared off completely. So once the tumor over here is completed, we can actually insert the endoscope inside, and we can, with the angled scope, we can see the superior extension as well, or the lateral extension as well. Here you can see once the tumor is cleared, this arachnoid has come down. So it suggests that the superiorly we have enough very good clearance, and all the sides the tumor was completely cleared, except a small portion on the left side where the paralysis happened. We used this is the G forceps, the giraffe forceps, but we use for frontal sinus. We used that. But at this point, I would like to mention that this is the very crucial area, because here we will find the paraclival the carotid area is very near to that. Anything over here, if it is not coming out with gentle pull, should not be pulled again. It is because you may not know what you will be taking out. So once that tumor is cleared, now this is the flap goes back and the fibrin glue. Finally, the fibrin glue and just Surgicel and 2 Merosil packs, the patient's fine. And that patient in the post-op period, here we can see the movement has been completely restored. This is because of the early presentation, we get to have a very good recovery within the 6 hours of the surgery. The patient have his vision, his paralysis was completely recovered. Thank you. That was my presentation.
Thank you, Kesavananda, for nice presentation. So, any more question from the audience?
Keshav, very nice presentation. I want to know 2 things from you.
Sir.
Theoretically, people always talk about exposing the 4 blues. Do you really believe in exposing the 4 blues all the time?
Not really, sir. Depends upon the tumor size and what are you expecting.
Yeah.
If this kind of a tumor, if it's a huge tumor, so we'll have to, usually it's an ideal situation. In any ideal situation, we usually have to look for the carotids, the OCRs and all. We have to have enough space below the cellar so that one say 3 size suction should be easily be passed below the cellar floor. So that is the amount of area exposure we need. Otherwise, it will be very difficult for instrumentation because there will be 3-4 instruments going on together.
And the other part is people always talk about removing the mucosa of the sphenoid and totally before putting the fat and everything else because you can have mucosil. Have you really seen mucosil in any patient, yours or anybody else's happening?
If I recall, there was one patient for sure because post-operative when we see the check MRI, there was one hyperintense shadow over there. So that confused the radiologist, but we assured that this was not there because of the inadequate removal of the mucosa. So there remained a small mucocele in the sphenoid. So that was left untouched. Macro, sir. Yes, sir. Yes, sir.
One question.
Sir.
See, from the difficult tumor around the great vessel, how do you dissect?
Sorry?
The tumor around the great vessel, carotid, how do you dissect? How do you take care of that part? Any special technique you do?
Usually we use suction irrigation. We have to continuously irrigate once after gentle the suction pressure has to be reduced, gentle curettage around the vessel. But if we have say for that, if you don't have any other thing like in terms of this thing, the navigation system, or you can have the ultrasonic visualization of that vessels, or you can have dye injected. These are the other techniques which helps to identify the vessels over there. If we are
the hydrodissection, you don't
yeah, that's a hydrodissection with gentle irrigation with the irrigation.
And one more question: in case of bleeding, how do you manage? Suppose you are doing surgery, there's a bleeding, venous bleeding. How do you manage?
It's a small vessel. You are talking about the greater carotid injury.
See, from the covenant sinus, there will be bleeding. So there's venous bleeding. How do you manage intraoperatively? While dissecting, there will be some bleeding. So how do you manage the venous bleeding?
We usually wait for some time after putting some Surgicel and
Any experience flow seal? Because we have been using flow seal. It really works.
Flow seal, yes. We have used flow seal, but I have not that much of experience with flow seal. I prefer not to use that because once it is used, you cannot then again operate over there. It's at the end of the surgery you can put flow seal because flow seal per operatively I don't prefer using flow seal. That will be like you will be stopping the surgery midway and you will have to come out. Sir. Okay.
One of the problem with our ENT is, see, pituitary surgery is not a difficult surgery.
No.
Anybody, ENT surgeon, in fact, pituitary one surgery where the neurosurgeons are taken over. Otherwise, it is within the domain of ENT, and one of the, in fact, pituitary without pituitary, but it's one of the more easier than medial enterostomy in related.
Yeah.
It's a straight way. Just open it, just create it, hydrosection, dissection, you just open it, it's going to fall down. So the only problem is when there is a bleeding.
Bleeding.
The ENT are lost, penetrated. But I think best has come with a good thing, and best has been a flow seal. Now in case of difficulty, flow seal really work wonders.
I keep usually everything standby. The flow seal we have at that standby, but I have not heard about the product over there that Dr. Subhama has said. So I will just inquire regarding that.
You just inquire that one because it will give you a very good advantage.
The cost factor is huge for over this part of the, where I am working and the kind of population I am treating here. It's getting giving a fibrin glue. It's very difficult for me.
Ayushman is there. Ayushman
is there. Actually,
So-
what we are getting from the consultant.
So we can stop here.
Keshav, I have a very
Okay.
Keshav, can I one sir, a very basic question. So I always confuse. You always use Haddad flap
Mostly.
mostly. It depends upon CSF leak or not leak. No.
Yeah, mostly.
If there's a CSF leak, definitely go for Haddad
Definitely
flap.
go for that.
Okay. I'm always confused regarding which is what is rescue flap?
Rescue flap, we don't give the inferior incision. You give the only superior incision and reflect everything down.
Yeah.
You do rest of the thing is same.
Okay.
And then you can just because the inferior incision is there already, is not there already, so the flap will go up again.
Okay. Thank you. Thank you. Sir.
So no more question, please, because we are running short of time. Okay.
May I invite Dr. Ajit Kumar Misal?
What is your protocol for the residual disease? Means sometimes in this case of big tumor, it's in the cavernous sinus area, so you are not taking out everything. So what should be the protocol for the residual disease?
As the thing is, ideally it is a decompressive surgery only. So if the purpose of the surgery, the decompression has been done properly, so usually I don't care about the smaller remnant. It depends upon the aggressiveness of the disease as well, because it's a very slow growing tumor, so it's not going to cause any problem very soon. Thank you.
May I call upon the stage Dr. Ajit Kumar Misong to present his video on infrahyoid flap for reconstruction of hemiglossectomy defects.
Good afternoon, everyone. Respected chairperson, senior faculties, and all delegates. I am going to present before you short surgical video of infrahyoid flap harvest and its use in the reconstruction of hemiglossectomy defect. Infrahyoid flap is a pedicle myocutaneous flap nourished by the superior thyroid vessels. It was first developed by Conley and Claremont and refined by Wang et al. Although it is not a workhorse flap in head and neck reconstruction, but it is a very useful flap for moderate size defects of oral cavity, particularly tongue and phloem mouth, when free flaps is not feasible. I am presenting here now the video, voiceover video. Please enjoy.
This is a case of squamous cell carcinoma of the tongue involving the left lateral border with infiltrative lesion measuring 3 into 2 cm size. The lesion is not reaching up to the midline. The base of tongue and floor of mouth are free. Paroral left hemiglossectomy with compartmental resection, that is type 3B glossectomy, is done. We can see that a defect is crossing the midline and reaching up to the base of tongue. Our plan is to reconstruct the defect with infrahead flap. First of all, surface marking of the infrahead flap is designed. It extends from the hyoid bone to suprasternal notch and from the midline to 3.5 cm width. Incision starts in the midline and it is deepened to include the ipsilateral stap muscles. Further dissection is done to island the design skin paddle. Once skin paddle is islanded, the skin paddle is sutured to the ipsilateral stap muscles to prevent shearing. For this, we may use 3-0 catgut or Vicryl. Once this is done, further dissection is done to identify the ipsilateral omohyoid muscle. Once the omohyoid muscle is identified, it is sutured to the skin paddle. The omohyoid is then divided so that the upper part of the omohyoid muscle is included in the flap. Further dissection is done to identify the superior thyroid pedicle following the upper pole of the ipsilateral thyroid lobe. Once the superior thyroid pedicle is identified, it is clamped and divided near the upper pole of the ipsilateral thyroid lobe. In doing so, we should be careful not to injure the external laryngeal nerve. Once the pedicle dissection is completed, the upper incision of the skin paddle is done and it is further dissected to complete the harvesting of the infrahead flap. This is the infrahead flap with the superior thyroid pedicle. Excessive skeletonization of the pedicle should not be done to prevent venous congestion. The superior thyroid artery is the first branch of the external carotid artery. The superior thyroid vein in this case drains into the common facial vein, which in turn drains into the internal jugular vein. Once the flap harvesting is completed, the skin incision is extended to the ipsilateral mustard process and we proceed for neck dissection. In this case, we go for left extended supraomohyoid neck dissection. Once the neck dissection is completed, the flap is ready to be transferred to the oral cavity. The flap is transferred to the oral cavity by pull-through technique. Before transferring to the oral cavity, we should check the reach of the flap, and once it is confirmed that the reach is adequate, the flap is then transferred to the oral cavity medial to the mandible through the floor of mouth. The mylohyoid muscle may have to be divided to increase the tunnel size. Once the flap is transferred to the oral cavity, flap insetting is done and reconstruction completed. This is the final appearance after the reconstruction is completed. we can see that the defect is very nicely repaired with the infrared flap. There is no congestion or immediate color change of the flap. This is the appearance of the tongue and the flap on the first postoperative day. There is no restriction of tongue movement. There is mild edema, but the flap color appears healthy. We can see that the donor side has been repaired primarily without tension. 4 weeks, this is the final outcome. We can see that there is good cosmetic and functional outcome.
চাও আগতকে ভাল পাইছে না আপুনি
পাইছো
চাও জিভাখন চাও জিভাটো উলাই দিয়ক
To conclude, infrared flap is an excellent alternative to free flap in the reconstruction of hemiglossectomy defect with good clinical and functional outcome. Thanks.
Thank you, Dr. Misong. It was really an excellent video in terms of video quality and your surgical work. Thank you.
Thank you.
Any question from audience?
What are the contraindications of infrared flap?
Thank you, sir. It's a very good question. In previously treated neck, like if there has been a neck dissection or irradiation, we don't go for neck dissection. Even if there is very extensive nodal disease with extranodal extension or skin involvement, we don't go for it. So.
Hello. I'm audible? Can you hear me?
Yes,
Hello?
sir, I can hear
you. What is the size of defect necessary to use this flap?
Yes, sir. Thank you. Sir, as you know, there are different types of glossectomies, like partial glossectomy, where only 1/3 or less than 1/3 is excess. There, I don't recommend for flap, the direct primary pen. For infrared flap is especially useful when there is 1/3 to 2/3 defect, 1/3 to half defect, sorry, 1/3 to half. And for more bigger defects where bulk is necessary, I would advise for this ALT flap, free flap. Sir.
Yes. So your flap
Yes.
here is based on the superior thyroid?
Superior thyroid artery and veins.
And the venous drainages?
Venous, the superior thyroid vein also.
Superior thyroid, okay. Then is this a sort of a fasciocutaneous, or can you call it a myocutaneous flap?
This is a myocutaneous flap, sir.
Okay.
All the strap muscles on one side has been used.
Okay, right. You separate the muscles from the hyoid bone or leave it like that? Or do you separate the upper end of the muscles from the hyoid bone?
Yeah. We
separate it. Otherwise, it won't go up.
Okay,
thank you.
Thank you, sir.
Very good.
Thank you, Dr. Mission. Now we conclude the video session.
Thank you.
Now may I request all the speakers of the video session to kindly proceed towards the felicitation corner. Dr. Arup Kakoti, Dr. Anjan Jyoti Bhuiya, Dr. Keshavanand Kaur and Dr. Ajit Kumar Misong to kindly proceed towards the felicitation corner. And I would like to request our chairpersons to kindly felicitate our speakers. Now may I request Professor Dr. Rupanjita Sangma ma'am to come forward and kindly felicitate our chairpersons.
Next is our Sivsagar Academy Neuro-Otology panel case-based discussions. The moderator is Dr. Srinivas Dorasala, and the panelists includes Dr. Nilutpal Datta, Dr. Surajit Barman, Dr. Paramita Chakraborty, Dr. Anjanjoti Bhuya, Dr. Supriya Chintham, and Dr. Tejasevi Chase.
From here I can present, or from that side I should present? I don't know. This side. From this side. नहीं ये बस है, लेकिन चार्जिंग पॉइंट चाहिए. चार्जिंग पॉइंट है, चार्जिंग पॉइंट दे दो बस. हाँ हाँ, yeah, that is empty. Whenever she wants she can come. कनेक्ट करके दे दीजिए.
हेलो हेलो
ऑडियो चल रहा है नहीं चल, ये तो भी चलता है ना, ये चीज उनको ऑडियो कुछ नहीं है उसको. नहीं ऑडियो का ज़रूरत नहीं है, ऑडियो का ज़रूरत नहीं है. ठीक है.
हेलो 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 हेलो.
Very good afternoon to all of you. My expert panelists welcome all on stage. Dr. Nilotpal, there are two Sadak Chap neurologists on that side. There is a Sadak Chap
hello
moderator standing here. Okay. So Dr. Nilotpal, Dr. Surajit, Dr. Paramita, Dr. Supriya, and Dr. Tejasvi. आ रहा है ना? आएगा? आ रहा है? आ रहा है. आ रहा है ना? या ऐसा है तो वहाँ आ रहा है. इसको भी थोड़ा कनेक्शन दे दो. उस तरफ से मैं उस तरफ लेके जाऊँ क्या? कनेक्शन दीजिए. नहीं वो नहीं, एक HDMI केबल. HDMI नहीं आ रहा है ना? हाँ. ये भी नहीं आया.
हाँ ये तो आ रहा है HDMI. Welcome to star batsman Dr. Anjan also. वो तो सही है, ये सब सही है. ऐसा आ रहा है तो वहाँ है, या ऐसा बदला है तो वो वहाँ डिटेक्ट हुआ है. आया आया ठीक है, ओके. वो कुछ नहीं होगा, वो सभी है, सही सही है. आ गया, डोंट वरी. पेन ड्राइव चाहिए? हो गया ना, ठीक है. स्विच. स्विच डायरेक्ट स्विच कर दो बस. Excellent, super, thank you. So very warm welcome to all of you. So we are going to start the panel discussion. I am going to take the opinion of the panel on a certain number of video cases and then present to you what exactly is likely to be the diagnosis. This is like a very simple way of reaching a diagnosis very soon, very fast, okay, without having to go through a lot of trouble. These are called street smart techniques, okay. So I will see how good our panelists are on street smart sadak chap techniques, okay. Because we need street smart sadak chap techniques. Otherwise, if you end up making the patient pay 25,000, 30,000 rupees, patient will come to the street. So we don't want that to happen. Correct? No? Yeah. नहीं आड़े की जरूरत नहीं है, वो वीडियो में सब है, डोंट वरी. आड़े की जरूरत नहीं है, ठीक है. ऑडियो देने वाले यहाँ बैठा है, ओके ठीक है. I want Surajit to elaborate on what he saw and what he thinks is the diagnostic approach for this child.
So, this is a young child. On the face of it, looks to be very imbalanced. The gait is very imbalanced and very afraid. So we can see the kid clinging to the mother because the kid is afraid of moving around. So every time the kid moves around, it tends to fall. So for diagnosing what this is, I think for diagnosing any kind of vestibular disorder, the most important thing is proper history.
Yes, super.
So since this is a young kid, we have to take the history from the parents. So first, and I think one of the most important question in the history will be duration. How long this has been going on? So, and how did it start?
Yes.
So was there any particular trigger factor to this?
Yes.
Whether that trigger factor was something, some disease, some event, something like that.
Yeah.
So that is
now,
very important.
Now I will give the additional. This was the beautiful point which he told. What the message is, don't jump to a conclusion based on just one video. The history is very important to tell. Now I'm going to give the history. What has been captured here is an entire maximum of 30 seconds, that's all. Now, this is episodic, this is happening again and again. No, kuch nahi. Oh, fir gaya. Okay. Okay. This is episodic, this is happening again and again. Okay. This is just a 1 minute event, that's all. For 1 minute, child is like this. After this is over, the child is normal. All these things have started happening last 3 months. Once in a while, once in 2 weeks, maybe once in 10 days, something like that. Suddenly the child has this episode of 1 minute, and then the child is otherwise normal. But during that 1 minute, child is grossly unstable, shows this one. Can you also see the eye movement? Just see the eye. I don't know. Just give me 1 more minute. If that doesn't happen, नहीं तो आप एक काम करो, पेन ड्राइव दो, मैं पेन ड्राइव में लगा के दूसरा लैपटॉप में प्ले करूंगा, ठीक है?
Window.
That is okay, ma'am. It's okay. That is okay. So now with that background that I have given, now I want Surajit to again elaborate as to with this background what is your diagnosis. नहीं है. हाँ, सोनू वर्मा. आ गया क्या? हाँ ठीक है. हाँ? लैपटॉप में हिलाएंगा नहीं, ठीक है, फिर भी वो पेस्ट भी कर देता हूँ, ठीक है? ये पेन ड्राइव में पेस्ट करने को नहीं दे रहा है. क्यों नहीं हो रहा है? इसमें नहीं होगा ना? इसमें पेस्टिंग का ऑप्शन नहीं दे रहा है, एक्सेस नहीं है. ठीक है, नहीं मैकबुक में है लेकिन इनका इसमें नहीं है. ठीक है, ठीक है, लेके जाओ. ओके, वो कुछ नहीं होगा. आ रहा है कि नहीं? नहीं आ रहा है, चला गया, छोड़ दो. मैडम, गिव मी योर पेन ड्राइव. So with that in mind, let us continue with the discussion. With that in mind, Surajit boss, please elaborate on what will be your diagnostic possibilities with this history, and then what is the diagnostic possibility if it was acute onset within 1 week, this kind of behavior constant, that will be told by Nilotpal. Now what is the diagnosis?
So now with a history of 3 months episodic, and
in that age group,
in this age group, otherwise on other time it's perfectly normal. One history I would like to elaborate more is mother's history of migraine. Because if that is their mother's or family history, I at this age could, with this history, could tend to still think of something like BPVC.
What is BPVC? Please expand
so
that.
So it's benign paroxysmal vertigo of childhood. It's can be considered to be a variant of migraine, although it's a little different from childhood migraine. And it is seen in children, very young age children, where the pathognomic signs are typical sudden onset dizziness, where the patient during that bout is very apprehensive, will just cling on to anything, but that stays for a few minutes, or even not even minutes, few seconds, and otherwise the patient is very well. It has a little longer history, 3 months, 6 months, and is usually brought about by some kind of an physical, mental, psychological, something, trauma kind of a thing, even a small one. And most of these patients, if we elaborate, we do find a familial history of migraine in this.
I want Dr. Supriya to please tell me how she is going to manage this patient.
Benign paroxysmal vertigo childhood is most of the time there is spontaneous remission, so we don't need treatment at the early stage, and it resolves on its own. So we have to observe the patient, and if it is not improved, then we'll continue with the other medication.
Super. So if at all a medicine is required, which is your choice medicine?
I will give cyproheptadine.
Cyproheptadine, excellent. Okay, that is the same, that Practin, which is given for hunger management and to make the child hungry. Okay, so superb. Now, all are video cases only. This, you saw that? Who believes in ghosts? This is like a ghost coming and throwing him off the ground. See there? Dr. Ranjan, your comments.
Hello. Yeah. This looks like a very forceful fall without losing consciousness.
Okay.
Patient is conscious just after falling. So he was trying to get up, and it was a very energetic fall. So maybe it's of a vestibular origin. It may be a drop attack or something like that.
So the points that he's trying to tell is, what are the main points that he's telling is that there is a lot of energy in that fall. It is not a collapse to the ground, it's the energetic fall is what he's telling. So second thing is, in that energetic fall also, though it is so dramatic, he is immediately aware, he's trying to get up on his own. So which means awareness is there. So because of all these things, he is classifying this as a type of fall called vestibular fall. Correct, sir? Now, if the person has a vestibular fall, what differential diagnosis comes to your mind?
Acute vestibular loss, that means
Maybe I can paraphrase it. What conditions? Like one condition that everybody thought of is Tumarkin's crisis of Meniere's disease. Anything else in vestibular that can cause this kind of a problem? Maybe Dr. Supriya?
It is likely to be autogonal detachment from the utricle.
So that you see in which condition? So pre-BPPV stage. Then anything else you can think of? So Tumarkin's otolithic crisis is one condition. There are some people just before the actual BPPV onset that somebody can fall like that. Anything else you can think of?
It can be a migrainous fall also.
It can be a migrainous fall also?
Previously we always used to think it is Meniere's, but nowadays in migraine also we have falls.
Excellent. So it can be a migrainous fall. Then what else? Anything else you can think of? That's fine. So we have, okay, Surajit boss or Nilotpal or anybody.
Nilotpal and me were discussing this. This can also happen, just like Supriya said, pre-BPPV. This can happen post-BPPV maneuvers also.
Absolutely. Post-BPPV maneuvers also it can happen. Then?
And one more thing what we can happen is there's a variety called isolated autolytic dysfunction. Now the otoliths are basically involved with the autonomic systems of the body, which regulates the blood pressure and the postural hypotension. So if there is a isolated autolytic dysfunction or the previous vestibular neuronitis affecting the otoliths, then there can be a sudden autonomic change in the body and then can lead to cataplexy like of a thing where there is a sudden loss of the muscle tone.
Fine. So I will, prompted by you, I will show both, okay?
But this is an energetic fall.
This is an energetic fall. So energetic fall means vestibular fall. So that is the panel's opinion. So and the panel is telling that in energetic fall, these are the different conditions they enumerated. Otolithic deficits, maybe pre-BPPV, just like the otolithic problem, maybe Meniere's disease, maybe migraine also can cause this kind of a fall. And then also, maybe one more thing, vestibular paroxysmia can
this be an ocular dependency of the vestibular loss?
Which one?
Visual dependency.
Visual?
Visual dependent, vestibular loss with visual dependency.
Will it cause a sudden thing according to you? Okay. I would want you to elaborate on that.
Yeah. If something moves on the eyes and patient is visually dependent.
Okay. What he is trying to tell is if the person is exceptionally visually dependent and if something in front of them moves, then they can have a fall. Okay, so that is visual dependency type fall. So all of these things, this is beautiful.
So can it be a type of vestibular paroxysmia?
Yes, vestibular paroxysmia. So that was the one thing. So we have listed a lot of conditions where highly aware patient with full of energy, as if they themselves, their muscles are throwing them down, is happening, and we listed all these conditions. Vestibular paroxysmmia, pre-BPPV, just otolith, Tumarkin's crisis, migraine, then what else? We told. So this is a beautiful panel. This panel needs a claps right now. Okay, super. Fine, great. Okay. So now they elaborated a lot of things. Somebody told about post-BPPV. Let us see this. This is Dr. Bhavin Parikh from Gujarat. This is his patient. He has just done a play maneuver. He's sitting there, and then he comes. I don't see a timer here because I need a timer, otherwise I don't know when to stop. Okay.
We still have 14 minutes left.
No, only 14 minutes left.
We can go on anyway. After our session is lunchtime.
No,
Lunchtime, okay, fine.
It's 14 plus. It's already lapsed.
Oh, 14 minutes have lapsed.
So how many more minutes we have?
We have 30 minutes.
Excellent, super. Then we can do it slow and cool. So he finished. He thinks he's happy. Now my question is to Dr. Paramita. Dr. Paramita, have you seen in your practice this kind of severe pulsions, throwings after your BPPV repositioning?
Sir, this happened once, but not with so much force, but it did happen.
So it did happen to you?
Once or twice, yes.
Did it make you change your practice guideline, the way you take care of BPPV patients? Anything you changed? Anything?
Yes, sir. Actually, post BPPV, usually we do not give the patients any medications. But in such cases, first is we have to reassure the patient. We have to make him lie down and...
so you are telling, my question is, I think I should ask it a little differently.
Yeah.
After you saw this kind of an event in your practice once, is there any precaution you are taking immediately after the maneuver? You are taking something?
Yeah, we have to hold the patient and make him sit somewhere.
Okay. So how long? How long you make them sit somewhere?
Actually, after the procedure, I learned from one of my teacher. He said immediately after the procedure, you should make the patient jump once, so that whatever debris are left behind.
Who is that? One of the teacher?
My guru.
Fine. Okay. Fine. Okay, fine.
So yeah, we have to take that into account and make
but
the
I
patient
think that
sit
was
for
told
some
to you
time.
by Surajit. Yeah, good, excellent. Okay, fine. So that was one. I think Nilotpal mentioned something else, so I will also do that. Okay, fine. Somebody mentioned something. So these are different types of things. Okay, fine. So we will go to this one. This is from Ravi Rajan. This patient is from Ravi Rajan. Okay. Now I will tell you the story. This question is for Nilotpal. This happens within the first 10-15 minutes of waking up from sleep. Okay, after waking up from sleep, this is happening. So what, and of course, I think, Nilotpal, do you consider this as an energetic fall, and what are your thoughts on this?
So there are two things. One could be, as you told, that could be a orthostatic hypotension, which occurs within 30 minutes of immediately sleeping up in the morning. What happens is, so in this patient, and there is an energetic kind of a exposure over here, and it could be cataplexy also. Now both the things are quite similar. That's the reason, as you have, I came to know from you about that practice which we do in these patients which comes to us with this isolated falls. Then we tell them to measure the test for orthostatic hypotension, the BP protocol which we have. And after that, in the morning, what we do in these patients is to take the dehydration amount of fluid intake, if it's less and there's a less fluid intake in the previous night, then these patients usually, if they have a preoccupied orthostatic or postural hypotension, then this kind of falls could be there in the morning.
So I think I was not very clear. This patient is not 15 seconds. It is after 15 minutes.
50 minutes.
15 minutes of waking
15
up.
minutes.
Not within 15 seconds of getting up.
No, sometimes it can happen up to 30 minutes from the when he wakes up in the morning, from 1 to 30 minutes.
Okay.
If he's not taking adequate amount of and if there is a orthopedic this postural hypotension in this patient, then it can happen up to 30 minutes from waking up from his sleep position.
So
if
postural hypotension is ruled out in this patient by a test, then what other differential diagnosis you will consider?
Other, we can have BPPV can project with similar kind of symptoms. I have one patient of mine, 2 times after getting up from the morning, why he was brought to me was similar attacks, his sudden onset of fall in the morning while having the breakfast. While getting up from bed, she was almost all right, some imbalance was there, but while eating, I think it was pre-BPPV which matured into the actual disease, and BPPV also in the initial steps, it gets so robust nystagmus that it leads to fall. So there is a possibility.
So that is the second possibility. So having ruled out orthostatic hypotension, having ruled out BPPV, what is the next thing that you will think of?
Cataplexy can be there.
Cataplexy can be there.
Cataplexy can be there.
And then?
And we need to take the history of any migraine. I don't know about the loss of consciousness because
there is no loss of consciousness.
Loss of consciousness because there is a syncopal migraine variant also which occurs early in the morning, which triggers due to a lot of empty stomach. So there is another variety.
So you want to think in terms of migraine also?
Migraine also. We need to take the history.
And you want to think in terms of cataplexy also?
Cataplexy. Yes.
Wonderful. Okay. So just to give you back this thing, this patient was treated as migraine and she became better. Okay.
Vertebral artery stenosis.
Can this patient be a vertebral artery stenosis?
Yeah. So then in that case, you want to see the video again? Okay. Was there any neck turning is what you want to see?
Yeah. The patient was turning.
Yeah, we will see. Yeah. We will see.
Extending her hands and...
Yeah. So no neck turning.
Okay.
No neck turning. Okay. So unlikely that it is a vestibular, correct? So it's good. So we see it with different perspectives. This is the beauty of a panel. Okay, they are seeing with different perspectives, and we are. Somebody write down this discussion. It will be great. Okay, superb. Okay, next. This is for Dr. Supriya. I want Dr. Supriya to elaborate on the findings that this is slow motion video, so we want to see that. Okay. See that? Rightward impulse. And then we are bringing the head back to the central position. And then again. Is that okay?
Yes,
fine.
sir.
So, Supriya ma'am, please elaborate on what you are seeing. And if this patient, first elaborate and then we will come to that.
We are doing a head impulse test on this patient. First on the left side, and then after pose, we are checking for the catch-up saccade. And on the right side, we are doing the head impulse, and then again, after a pose, checking for the catch-up saccade, and we can see abnormal head impulse test on the right side.
Is it only on the right side or is it on both sides? You want me to play again? I'll play again. Head impulse is needs.
Yeah, we have it in right.
So see that?
Both sides.
Okay, both sides it is impaired. So now, if it is both sides impaired, and if this person comes with a history, my main problem is I am having a lot of difficulty walking, doctor. I think I'm not sure-footed. I think I'll fall off anytime. What will be your diagnosis?
Bilateral vestibulopathy.
Bilateral vestibular loss or bilateral vestibulopathy. Now, what will you do for this patient? vestibular rehabilitation. So can you just elaborate what you do exactly to help these kind of patients in your practice?
We'll do the muscle strengthening exercise and then other BOR strengthening exercises.
Okay, okay, fine. So generally, how long do they spend, how many visits they'll have to come back to you so that they come back to normal, able walking?
Actually, we advise for 6 months non-stop vestibular rehabilitation.
Okay, super, great. Yes, avoid medicines, avoid vestibular sedatives, okay? This is for Dr. Anjan. If you see a patient like this with a Ryle's tube and with this kind of nystagmus, what thoughts come to your mind, sir?
It's a downbeat in the right gaze and downbeat nystagmus in the left gaze. So it's a downbeat nystagmus syndrome.
It's basically a downbeat nystagmus syndrome.
Yes.
Fine. So what are the differential diagnoses of downbeat nystagmus that you can think of from Nilothpal 1111 differential diagnosis up to here? From that side it starts, it comes up to Dr. Tejasvi. Okay.
Most common is the cerebellar floccular lesions.
Okay. So
downbeat nystagmus mostly again central. I'll always think of migraine. I think that is the commonest presentation.
if it is episodic.
Okay.
Yeah.
It might be paraneoplastic cerebritis.
Paraneoplastic is one thing that you can think of. Yes. Paramita ma'am, anything else in downbeat that comes to your mind?
It can be a vestibular paroxysma also. I agree with Surajit, it is, can be due to migraine or any other central lesion, but it can be a paroxysma also.
It can be it can be because of a cross compression. Where is the
Yes,
where is the compression? Is it only because of a blood vessel pressing it, or anything else also can press on the brainstem structures?
Yeah, it can be a neoplasm.
It can be a neoplasm
or
pressing the
vascular loop also we usually
vascular
see.
loop can press. Then what else can press? What else can press on the brainstem structures? Dr. Supriya? So these are great thoughts. See, this is what we are seeing, the thought process flow. Something can be pressing. What can be pressing is the next question. Yeah. Arnold Chiari, is it possible? Yeah. Okay. Okay. Dr. Tejasvi, anything more you can think of?
Sir, it's downbeating.
Downbeating is there?
Yeah.
Yes. Great.
So it's definitely it's of central origin. So like central positional vertigo.
Central positional vertigo. Yes.
Vertigo,
Okay.
yeah. So very
yeah.
likely it can be it can be because of vestibular migraine.
Yeah. So that from Surajit, I think Surajit has a lot of influence on everybody. Okay.
No, but
Next time I'll make him the last person, not the first person. Then what
central
else?
origin, yeah.
So what the entire panel from that side onwards, we started off telling, okay, other causes like floccular lesion is what Nilothpal told. Some kind of a dysfunction in the brainstem or in the cerebellum because of migraine or anything else. Then that Dr. Paramita again started telling that kind of a discompression can be caused by something pressing, that it can be caused by something pressing on those brainstem structures. Great. Fine. So what can be pressing on
in
them?
this patient, there's another thing.
Yeah.
I can see. I think this patient is on Ryle's tube.
This is on Ryle's tube, yes.
So unlikely to be migraine.
So fine. So
how
now
many migraine patients are we going to put on Ryle's
No,
tube?
we will not. So
So
what
it's
is it?
something organic in the brainstem.
So you also mentioned that you told Arnold Chiari.
So or it can be a some form of RTA, some blood clots pressing over something.
Something is pressing, right?
Yeah.
So I will tell you what was pressing in this patient. It is basilar invagination. It is the front of the foramen magnum which is pressing on the this thing. So there is something pressing, and that is what we. So generally our studied guesses are most of the time right. Okay, great. More energy for more cases? Yes or no? Where? Sleeping. Discussion. No. Who has more energy for cases? Raise your hands. That's all. Only half the hall is raising your hand. Okay, fine. So more. Now, this person comes to me with oscillopsia. after oscillopsia, this is open. Whoever wants to, from the panel wants to answer this can take and answer. And then when I look at the throat, I start seeing this one. What is the finding and what do you think is happening in this patient? Palatal myoclonus from the panel below. Great. Who was that? Yes, excellent. One more chair is not empty. Otherwise, I could have brought you up. Okay, great. So, what is the reason for the oscillopsia? He's seeing the entire world is dancing up and down, up and down. So, what is happening? What is causing the oscillopsia? So, Dr. Paramita was saying, is it bilateral vestibulopathy? So now, if a person has oscillopsia, there are two things we think of. We think of bilateral vestibulopathy, correct? So what we are supposed to do if somebody comes with oscillopsia? The next question is it sitting oscillopsia or is it walking oscillopsia? Oscillopsia during walking is bilateral vestibular loss. That is because the VOR is non-functional. The person cannot stabilize the seen world on the retina when he is walking. This person is having sitting oscillopsia. So sitting oscillopsia is part of, what is this called? Palatal myoclonus. Along with the eye, if there is, the eye also is dancing like this and with this, what is that called? Can we call it? Huh? So there will be a pendular nystagmus, so that will be oculopalatal tremor. Okay. So that eye also and this one also, both of them together is what is causing this problem. So we are finding out, this is all pattern recognition. The moment you see somebody is having oscillopsia, next question is sitting or walking. Walking means bilateral vestibular loss, sitting means it is a oculopalatal tremor, that is pendular nystagmus. Okay, fine. Great. So we will see one after the other, one after the other. We have time, I think? Good. We have 15 more minutes. We can do merry in 15 minutes. Great. That cause is a small stroke in GM triangle. Anywhere from the dentate nucleus to the red nucleus to the inferior olive. In between these areas, somewhere there is a small stroke can cause this. A kind, considerate doctor who has attended as an audience or as a panelist this panel will diagnose it. That's it. Okay. It need not be, see, I don't do professional casteism. For me, it doesn't matter. Okay. Whether it is a neurologist, whether it is a ENT, whatever it is, it doesn't matter. For me, who is interested in the patient, who has the time, who has the knowledge, who has the caliber, that's all. That person will diagnose it. Fine. Here what I am doing here is, I am taking the tuning fork, instead of what was taught in my medical college, I am taking to the other end, keeping it in the malleolus. Yes. Dr. Tejasvi, what comes to your mind? So, of course, now what Dr. Anjan is telling is, I keep the tuning fork, we are keeping the tuning fork on the malleolus to test for vibration sense, that is 128 Hertz. Here I am keeping 512 Hertz, that is not a vibration frequency. And patient is telling, sorry for not having the audio, patient is telling that sound is hearing here. That is what is symbolizing. See here. Distant sound from the malleolus he is hearing. He is telling he is hearing that sound. The tuning fork he is hearing there. So anybody guesses as to what is the diagnosis? Third window syndrome. So third window means what?
Superior canal dehiscence syndrome.
So superior canal dehiscence syndrome. So this is, what is this test called? Malleolus sign. Okay, malleolus sign. So this is going to be causing. So this is one way in which, one simple Sadakchap way of finding out whether the person has, okay, a canal. So now we always come across these patients from the emergency. Any postgraduates here or everybody busy presenting their papers? Paper finished. Okay, fine. So, because postgraduate is the first person of contact in the emergency. This person comes. This is courtesy Dr. Balamurugan. Okay. So, this person is telling, he is making to stand and he is leaning to one side. Can you see this? He is leaning to one side. See, the moment the eyes are closed, he is leaning to one side. Correct? Fine. Eyes open, he is somehow able to manage, but eyes closed, he is leaning to one side. Is that right? Fine. Okay. Who wants to take this? What comes to your mind when you see this kind of a patient? Who tells?
Vestibulopathy.
Or with the moment
with
his eyes closed, his see the feet, they are so much apart. Okay. And the moment he closes the eyes, he is trying to, so he wants to open the eyes. The moment you ask him to close the eyes, he is tending to lean to one side. You see that? This is his presenting complaint, that he is leaning to one side. Okay, he is leaning to one side. What comes to your mind? Yes, Nilotpal.
So this could be termed as acute cerebellovestibular syndrome.
Okay, acute cerebellovestibular
acute
syndrome.
cerebellovestibular syndrome. It can have two differential diagnoses. What could be a acute vestibular neuronitis of one side. Other way around, it could be a ICA stroke, which will also have a pseudo-vestibular neuronitis syndrome.
So his hearing is normal. If his hearing is normal?
Gait is normal.
So, no, hearing is normal.
Hearing is normal. It could be mostly vestibular neuronitis, but in ICA stroke also, ICA and PICA also, sometimes there are some lesions where the...
So if his hearing is normal, is it still possible that he has ICA?
No, then PICA.
Then PICA.
Then
okay.
PICA.
Okay. So what is this sign called that he is leaning to one side? Yeah.
Pulsion.
So that is ipsipulsion or latropulsion. So latropulsion, if you see in the emergency, what should be the rule? Generally, a person with unilateral vestibular loss, even with feet closed, feet together, with eyes open and eyes closed,
will be able to stand straight.
Will be able to
stand straight.
Will be able to stand straight. Okay. So this is what Dr. Nilotpal is telling, acute
cerebellovestibular
syndrome. So the person is showing this kind of a tendency with fast. This is something that is not easily known. And this is a very, very important discriminating finding, that knowing that a vestibular neuritis or a acute labyrinthitis patient can still stand well with eyes open and eyes closed on a stable surface. On a stable surface is a very important discriminatory finding in the acute emergency. In the emergency, very important discriminating finding in the emergency. This person doesn't want to do that. Okay. A vestibular neuritis patient may want, but if you force him to keep the feet together, he can still keep the feet together, and with eyes open and eyes closed, he can stand without leaning. The vestibular neuritis patient's problems start becoming manifest only on the foam. Okay, only on the, when you remove the proprioception. So that is an important discriminating finding. So as he immediately told vestibulocerebellar syndrome, so that is what should come to your mind. Okay. So what it is, if the hearing is normal, it is likely to be which blood vessel?
PICA.
PICA. Excellent. Now one more test. Okay. There is no audio, but then I will show him. Is it possible to arrange audio from here? Yeah, I have connected audio. Let us see if it plays. How much more time is there? Accordingly, I will plan the 5 minutes. That's all. 8 minutes. That is great. Again, the use of tuning fork. Now I am using tuning fork for what? Don't be my medical college professor and scold me that you are putting the prongs, not the stem.
This one? Hold it. Pinch, paining. It's paining. Pinch? I'm feeling. Pain you are feeling, only pinch? Only feeling, only I am feeling pinch. No pain.
Did you hear what he is telling? When I pinch on the right hand, he is feeling the pain. Left side feeling no paining. He is feeling it, but he is not having a pain.
I'm feeling pinch.
Cold on this side. Tuning fork feels cold on the right side of the body. Tuning fork is not feeling cold on the left side of the body. Dr. Anjan, what is this test called? So what does this suggest to you? What pattern of a sensory loss are we seeing?
Unilateral, maybe one side.
One side of a body.
Medial pontomedullary lesions.
So likely that, see, on one side of the body you are seeing a loss of sensation for the temperature and pain. That is the spinothalamic tract. Is that correct? Great. I think I'll stop this video so that otherwise both audios are missing. If you see acute vertigo patient, this one is a little beyond the acute vertigo stage, but had you done this test in acute vertigo also, this would have come. So what does that suggest? If you see an acute vertigo patient with this finding, what does that suggest for you?
There may be some demyelinating lesion inside, or there is a stroke.
There can be a stroke or there can be a demyelinating lesion. So basically you are telling that it can be something in the brainstem, either medulla or pons. Is that correct?
Yes, sir.
Super. This patient presents with history of positional vertigo. Okay. We are taking the camera to the side and then we are making her. That is the real-time head animation and that is the eye video. What nystagmus are you seeing in the Dix-Alpine test of the left side? Is it dramatic, the nystagmus, or is it confusing on day one?
Confusing.
How many of you think it is confusing?
Confusing.
It's a bit confusing. How many of you think there is a horizontal nystagmus? How many of you think there is also a upbeating torsional nystagmus? Okay. In the audience, how many of you think there is a horizontal? This is the half Dix-Alpine. The head is lifted up. So this is how we do the Dix-Alpine test. Okay. We do the half Dix-Alpine, full Dix-Alpine, everything. Okay. Full down, head was down. Then we lift up the head. In the audience, how many felt that there is a horizontal nystagmus in this patient? Okay. In the Dix-Alpine position, the head is down. How many of you thought there is a horizontal nystagmus? Raise your hands. Excellent. How many felt that there is an upbeating torsional nystagmus there? How many of you? Great. How many of you think there is no nystagmus? How many are waiting for the lunch? Because there are some people who have no opinion. These are the nota people. No, none of the above. Okay, fine. This is how we do the Dix-Alpine. We bend the head first down. This is the side view. We are taking the camera to the side to show the head animation. This is new technology built in India. Then again she goes to the Dix-Alpine on the left side. Now what nystagmus? Upbeating torsional. Which nystagmus? Dr. Anjan, which canal?
Upbeating left, so it's a left posterior canal.
Left posterior canal. So day one it was not at all clear. Day two it is very clear. She was not on drugs, anything. So what does that emphasize? How often do you see this picture where the patient is actually comes with history of BPPV, but you get nothing on day one, or it is not very clear on day one, but somewhere you get that evidence that there may be upbeating, like some of us could see that, but it's not very clear. But then afterwards it becomes manifest. How often do you see this? Very often. So you often so what is the practice guideline you want to give to your colleagues based on this kind of an experience that you commonly see, where the patient that is the hemidixalpike position. We do the dixalpike, we always make the person come up to the hemidixalpike position and then see. Can you see that become more prominent in the hemidixalpike position? That was less in that position, but here it is much more prominent. What does this tell you? In the hemidixalpike, the nystagmus becomes more. What does this tell you? Cupulolithiasis. Excellent. So the panel is telling that if the nystagmus is more prominent, not in this position but on the up position, then it is cupulolithiasis. Okay. What is the implication of cupulolithiasis for you? What is the implication of cupulolithiasis for you? The implication of cupulolithiasis, you will immediately tell the patient that unlike the canalolithiasis, which becomes better within one day, in cupulolithiasis you will not promise that to the patient. You will tell you will have to come back 2-3 days. Correct? No? Fine. Huh? You can go for a Simon test. So it will help you in deciding which is. This case is for Dr. Tejasevi and Dr. Anjan, both of you. Of course, it is open to the entire panel, but. So this is how we do the dixalpike. We bend the head forward first. Then we take the person into that dixalpike position. Is there any nystagmus there? Yeah.
Yes, left torsional.
Left torsional, correct? Yes. Dr. Anjan, once I told him that this is for him, then he started seeing the main screen. Okay.
And there is some upbeat component.
There is an upbeat nystagmus. Okay, good. Okay. Is there an oblique component also?
Yeah.
Now this is what position? Hemidixalpike or semidixalpike position. Okay. Now, can you see? So what is this? This is, in which position was it more prominent? In hemidixalpike. So what does that suggest?
Posterior cupula.
What does that suggest?
Left posterior cupulolithiasis.
Posterior canal cupulolithiasis, fine. If you see this, to confirm that it is cupulolithiasis, what will you do? To just confirm. What is that being done? This is called inversion test. Dr. Nilotpal is telling it. That is an inversion test. Excellent. So what happens in the inversion test? What are you supposed to see in the inversion test to say that it was actually a cupulolithiasis? Reversal of the nystagmus. Okay. Do you see the reversal?
Yes.
Did the upbeating become downbeating?
Yes. Downbeat, oblique type.
Yeah. Yes. So upbeating became downbeat. So what is happening when I am changing the position? What is happening when I am changing the position?
Reversal of nystagmus, yes.
No, when the head is moving, what is happening? See, the head is moving now. The head is rotating from right towards the left in a horizontal plane. How many more minutes left? Huh? 10 seconds. I crossed the time. So now I'll just move the head. So when I'm moving the head horizontally in that yaw plane, what is happening?
Left beating.
Did you see a left beating nystagmus when the head was turning to the left? Did you see that?
Yes.
So when the head was moving to the left, I saw a left beating nystagmus. See that? See that?
Yes.
So what does that mean? Turning the head left beating nystagmus, what does that mean?
Left horizontal.
During the act of moving the head, if it is a left beating nystagmus, what does that mean for you?
Okay, that is normal, sir.
It is normal.
Yeah.
It is normal. Excellent. So it is normal. Means per positioning nystagmus is normal. Only post positioning nystagmus suggests that it is a pathological.
Yeah.
Why this is very important? Because if you, without this, only looking at the video, if you make a diagnosis, Only looking at the graph, if somebody is trying to make a diagnosis, it is wrong. That is why you should not go for remote reporting. Reporting has to be done by yourself. Reporting has to be done by the person who is doing the test. Okay, even if God is there on the other side, however far or however near, no remote reporting. Reporting has to be done by yourself, and this is very simple. Is that right? Okay. So with that, I thank my expert panel. Thank you so much for bringing out all the thoughts and so much. There were another 3-4 videos, but then I think it's okay. Okay, fine. Thank you so much. Big hand. This is not enough. Thank you all. So we go for any felicitation or
I would now like to request the moderator and the panelists to kindly come forward to the felicitation corner. I would like to request Dr. Bijoy Bonia and Dr. Nitya Gogoi to kindly do the felicitation.
Oh, that is narcolepsy.
We'll resume our session at 2:15 after a short lunch break.
Thank you, thank you, thank you.